and annuloplasty mode. We-
So, what is your take on thermoannuloplasty?
Huh? Sorry.
What is
What
your
is the
take
question?
on thermo?
Sorry.
thermo-
We don't do that.
So this is the end.
Surgery. This end of
This
the
is
decompression is going to take the, is going to take the scope of stopping the saline flow. You can see that there is good hemostasis, only a little bit of venous ooze that is coming, which is quite acceptable, and is taken out the scope. So can we have a round of applause for Dr. Rohit, please?
Yes. Wonderful surgery.
Wonderful, excellent.
Yes. Thank you, Dr. Rohit.
Thank you.
Yeah, excellent.
Yeah, come early to hall. We will have now tea and coffee.
Just last question. So to check hemostasis, would you close irrigation and check hemostasis, or
Yeah.
with the same irrigation you
Yeah,
would
exactly.
check
So you just stop the irrigation, and if there is continuous flow of blood from some source, you restart irrigation and control it with coagulation mode of RF, and then close it. Thank you, sir.
Okay.
Do you keep drain routinely or you don't?
If I'm happy
no
with the
drain.
hemostasis, I'm not using drain. If I'm not happy with the hemostasis, I'll use a drain for 1 day.
So now we'll have a break for a tea and coffee, and then soon we'll join again for live surgery.
Yeah. Yeah. Yeah.
Thank you.
Hello everyone. Hello everyone. Tea, coffee. Please everyone join inside the hall. We will starting with relive surgery session. एक और खाली bring your tea and coffee and please take a seat. We are starting a session. Everyone please take seat. We are starting with relive session. Our another UBE case is getting ready inside the OR. So till that case get ready, we will have a relive surgery demonstration by our SAG secretary, Dr. Rakesh Luhana sir. He will be demonstrating monoportal endoscopic lumbar canal stenosis decompression. So over to Dr. Rakesh sir.
Hello, good morning. So good morning, everyone. I'll talk about monoportal endoscopic lumbar canal stenosis decompression. You can stop me in between. Any question, any confusion, please stop me and you can ask. So this was a 68-year-old lady who presented with bilateral leg pain of 6 months. She was unable to stand more than 10 minutes, walk more than 100 meters, and had acute severe right leg pain with right foot weakness for 1 week. So basically, her history tells me that probably she had a background lumbar canal stenosis, and with the recent, maybe some acute disc component or a facet cyst, which will be causing recent worsening. Right EH read was grade T by 5, and this was her MRI showing L4-5 severe stenosis with disc. That axial scan showing L4-5 severe stenosis with maybe some component of disc herniation. So first thing is choosing approach. So my plan was to do an endoscopic monoportal L4-5 LCS decompression. So as patient has a right-sided symptoms more than the left, this stenosis looks symmetrical. It may be disc on a right side, so I chose the approach from a right side. Before that, getting flexion extension X-ray to rule out instability, so there was no instability. In endoscopic surgery, AP view also becomes important to see how much is the canal. Like this is trifoliate is the canal. Where is the pars? How much bone drilling is required? So AP view becomes important. Under general anesthesia, position is prone on horizontal bolsters. Some people use Wilson frame as well. I used to use Wilson frame, but over time I've found not much of difference. So my choice is putting bilateral 2 horizontal bolsters. Docking. So for docking, you identify basically spinolaminar junction. So I use a needle and a knife, and then place the. So basically, monoportal is a single dilator system. You put a dilator sheath and then put a scope in. So there is a dilator over which sit, and then you put a scope in. So once you are there, you use RA for plasma coagulation. Sorry, that's labeling is wrong. That's rostral, that's column. So identify basically spinolaminar junction. So this is medial, that's lateral, that's rostral, that's caudal. So basically you identify L4-5 spinolaminar junction. So you begin at the start drilling inferior aspect of the superior lamina, which is L4 lamina here. So for drilling, you go from superficial to deep. So first cortical bone, then you will see red marrow, and then you will see inner layer, which is again a white cortical bone. So that's how you would see how much depth you need to go. So there you can see that's a marrow and that's the inner cortex. So you reach till upper border of the ligamentum flavum, as we have seen in excellent surgical demonstration today morning by Dr. Rohit. So you reach till upper border of the ligamentum flavum, and then you come laterally. So choice is surgeon's choice. You can either use a cutting burr. Some people use all diamond burr, and initial practice one may use a protected burr. So I predominantly use cutting burr, and in elderly patients or osteoporotic patients where there is a lot of bleeding, I switch to diamond burr. So keep drilling till. So basically, you have to decide like at L4-5 or ligamentum fleum for removal of ligamentum fleum. To reach to the tip of the ligamentum fleum, you might have to drill lower third of the superior lamina. As you go higher, the drilling required is more, and at L5-S1, very minimal bone drilling is needed. So you drill superior as well as the lateral. Now you can see I am probably reaching till the level of upper border of the ligamentum fleum. And then you can use Harrison punch to come lateral. So that's a midpoint, that's upper part of the ligamentum fluum, and then you come lateral. So when you come lateral, you have to see where is the pars. Try to preserve pars at least 3 millimeter of thickness of pars, and don't come too lateral. So that's the lateral border of the ligamentum fluum. And then you turn toward opposite side, and that's the midline. And basically you have to drill base of the spinous process, medial aspect of the lamina, and go on opposite side. Right side. Busy. So that's the right side, that's medial. So I'm drilling basically now medial aspect of the lamina and the base of the spinous process to reach to the opposite side. So here I have switched to a diamond burr. Till you see the lateral. One thing is, if you are inner layer, you will see lateral margin of the ligamentum fluum. Or if you are drilling on the upper aspect, you will see the bone getting thicker there and you reach to the pedicles. So you stay medial to that. Yes. So you reach to lateral margin of the ligamentum fluum, and over which you would remove the overlying bone basically. So that's the opposite side upper margin, and then you drill little more towards cranial in the opposite side. I'm using dissector to see how much thickness of bone is there. In that way, you can decide how much more drilling needs to be done. I usually use piecemeal. Yes. Okay. Ipsilateral half full and then opposite side full. I think dural tear chances are, uh, I think, over feared. There is a lot of magnification. Even if any you theoretically, yes, means you are putting so much bone greens. Mahesh, what do you take? Huh? Oh, use butterfly technique. Split in the middle. One half here, one half there. Okay. I think what works best in your hand and what is safe in your hand, that an endpoint is important. Yes, that should be the rather aim. Okay, so now I'm removing ligamentum fluum. Again. Yeah. Yes, I do. I do use burr at the caudal lamina, and in fact many times where there is inferiorly migrated disc, I don't go up. Just burr lower side, separate the inferiorly migrated disc. And in a cases where either a redo case or very tight stenosis, in that case also separating from lower is much safer and easier. So very important at each stage you have to make sure that you are not getting hold of nerve root or a dura there. So make sure that you see where your punch is going and bite accordingly. And again, going from rostral to caudal is a safer approach where you go lateral to the traversing root so that your traversing root is safe. And I would say approach endoscopic surgery as you have been trained using microscopy or MIS. Don't think endoscopy is more minimally invasive or you need less bone removal or less ligamentum removal. Your ultimate endpoint remains same whether you do open, MIS or endo. It's just approach that is changing. So you have to have an adequate bone removal, you have to have adequate ligamentum fluum removal, you have to have adequate root decompression. So you can compartmentalize, like I'm removing ipsilateral upper quadrant, that's upper lateral recess, and then coming down. So you decide into 4 quadrant, ipsilateral superior, ipsilateral inferior, contralateral upper quadrant, and contralateral lower quadrant. That way you can make sure that your all 4 quadrant dissection and decompression is complete. It's also important during early learning curve that your sheath remains outside. At times, if you're not cautious enough, your sheath gets in and that may compress the nerve root or a fecal sac basically. So you have to make sure that your outer sheath remains on a bone at some point. This is inner channel is 5.7 millimeter, 10 millimeter outside that basically. It's a stenoscope. So advantage is you can use wide burr, you can use punch size up to 5 millimeter. You can see that's ipsilateral lateral recess, that ipsilateral L5 root, that's axilla. So now reaching to the lower border, ligamentum flavum attached to a L5 lamina that should be removed. So when you take a bite, every time there may be a chance in a severe stenosis that you may take a dura or root along with it. So visibility is important. That's ipsilateral foraminotomy is being done. No, that's in a biportal, the portal get reversed. This is monoportal surgery. Whether right, left, it doesn't make any difference. Yeah. It is just like a open or MIS surgery for a right-handed surgeon. Left side is easier and more convenient, but as such, it doesn't make any difference. No, 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 nothing. No, nothing. It's just you're standing on the side of the pathology. It's same. Yeah. Yeah. You just change the side. It's just like doing MIS or microscopy, same size. It is basically a channeled scope, so you go through the same channel. Yeah. So biportal handedness is important in biportal, whether you can approach from one same side and going on opposite side, or you have to change the portals. That's a contralateral foraminotomy is being done. That's the left side.
Any question from the audience? Yeah, it's a interactive session. So you can ask at any point, anywhere you have doubt.
What is your take on multi-level stenosis? I mean, any special tip for multi-level?
Hello, are we audible? Hello,
Hello.
साहेब लोग, are we audible? Hello,
We are ready at 2T. So we'll continue this after.
Hello.
yes,
So
can
we are
we?
ready at 2T.
Yeah. So basically,
Dr. Ubay?
can I speak, Rohit bhai?
Yes, Dr. Ubay.
Yes.
Yes, please.
So this gentleman is having by claudication, severe lumbar canal stenosis at L4-5 level and L3-4 level and L2-3 level. So we have planned the 3-level interlaminar decompression. At L4-5 level, we'll do biportal endoscopy and we'll try to remove the ligamentum flavum end block, so that we can have we free the ligamentum flavum from the oral corners, and we'll try to remove in the end block. And you see now on the here, can you show here?
Yes, can you zoom in
Yeah.
on the MR?
Can you zoom the MRI? Already have in your mobile. If you want to see, so all the MRI images we already share in the group, faculty as well as delegate group.
Okay.
Okay. So now coming to the surgery patient part, you can see now very good free flow. So this is most
Okay.
important part.
At L4-5.
Yes, we are starting from L4-5. L3-4, L2-3 will do monoportal endoscopy, because in end block it takes little time than normal usual. You see now the fluid from the
Yes,
working
yes, you can
portal,
see the
it's freely flowing. So
flow.
this has to
Yes.
come. Once you achieve this, then proceed for the further surgery. So with a little bit of using RF, we have identified the spinal minor junction. Can you show this CM image to them? Can you see it?
Yes, we are
See,
at spinolaminar junction.
So we are exactly on the spinal minor junction. I can see the base of spinous process and the lamina also. You can see this interlaminar window. The laminar window is very narrow, and you can see the lower spinous process also protruding into the interlaminar window. So we slowly enlarge the window and we'll start drilling. Okay. So if you have any question in between, just ask me. I'll try to.
Yes, sir.
Okay. So now we have triangulated the shaver also. This is striker TPS system. So I am just started drilling base of the spinous process. So this is what I am saying. You don't need to do everything, identify everything in a one go. Identify spinal minor junction first, then slowly drill the bit and make yourself very much oriented. And when you need to do a contralateral decompression, make sure that you drill the spinal minor junction and base of the spinous process very well, so that you can reach the contralateral very easily. So first layer we drill, and now again I am going to interlaminar window, and again I am drilling. So all this soft tissue is coming in the way. It is not necessary every time to remove that soft tissue, but if in the beginning of your surgical, so I'm just try to. So you see, when your hand is facing towards your scope, don't start. Always try to face away from the scope, because
Yes,
the
otherwise
very most
you
common
can damage the
complication
scope.
of UB is scope damages, because
Scope
we are
damage,
working
yeah,
with
yes.
independently two portal. So initial in your initial career, if you break the scope, then you will get discouraged. Okay, so don't break the scope and don't use in front. So once I remove a little bit of bone, now I have more orientation of the interlaminar window.
Gopesh,
Yes, sir.
how often scope damage happens?
Happens. I have damaged two scopes, one scope, and one scope damage हुआ पर repair हो गया. That was good.
So basically start with Chinese scope.
Yeah, that would be better.
But Chinese scope vision is there is
Not
some
that
issue
good.
with vision, because whether with the striker scope or the Chinese scope, there is a difference in
No.
suboptimal, because depth perception is change hota hai. Because
Sir,
we use in
what
scope.
I believe with the Chinese scope, that glue in the lens, which stuck the lens together, is not that stable at German scope. So what happened after some time, if you surgery extend then more than 40 minutes, then it start melting and your vision suddenly become hazy. You know, so in initial practice, you takes time. So at that time, if your vision is not good, then you get discouraged.
Yeah, so message to juniors is buy good quality
Good quality
equipment. It's very
scope. So
important
the
to have
RF,
a good scope, good camera. Otherwise, in initial practice, you will get discouraged. Once you become expert, I think that maybe it's okay to.
then when any scope will you can finish the surgery.
Yeah. So it works contradictory. In fact, at early practice, you will invest. Yeah.
Buy the good scopes and good instruments.
Saisha will not agree.
In fact, investing will give you some, motivation to work more
Yeah.
and learn endoscopy as well. That is also
Correct.
important.
So when I start my practice with the
So question is, what is the size of the burr? Which burr it is?
this is a 4.5 mm. It's a acromatizer. What we use in shoulder arthroscopy.
What is its name? Aqua?
Acromatizer. It is we use for the acromia base of the acromion process burring.
But I think they use very less in shoulder now.
Yes, more in the spine.
Yes.
RF. So this is a base of spinous process. To get in contralateral side, you need to drill it up. So our primary goal is to identify the midline. Okay? Every time you should try to identify the midline so that you can know how much ipsilateral and contralateral you need to go.
Okay, so first you will burr the
Base,
base of
base,
spinous
yes,
process,
yes, yes.
and then on in ipsilateral side first or contralateral first.
Whichever you want. If you have enough space,
Okay.
you can do ipsilateral first. If you have not enough space, then do a contralateral first. Okay, RF?
Okay.
Now I'll go through my
Bhupesh, doing monoportal as well as biportal, apart from visibility, what changes? If you're doing monoportal, you would do the same way as biportal, or you would have some
Yes, I
different
would do the
technique?
same thing with the monoportal and biportal, but only thing my two hands become free and independent to each other. So my restriction will go with the biportal endoscopy. So in stenosis, I'm more liking of biportal endoscopy, but yes, disc I still prefer monoportal because you can easily remove the disc with the monoportal scope. So after some time, you can also remove this lower port retractor also, because once flow established, then you don't need to. Okay. So. I have one idea now. 4/6 of.
I think there is a plastic there.
Yes, that's why I'm just.
It's a unidentified object inside the UFO.
है. Yeah, ठीक है. Yeah.
બધા નહીં કરવાના આમાં ઇમ્પ્લિમેન્ટ થઈ જશે હવે એક કરો ગઈ અને છેલ્લું રિલીઝ કેલિપમાં કેવું છે એક જ રિલીઝ બતાવવાનું બાકી બધું પલટી દેવાનું
So, Dr. Bhupesh, if you are planning for UB TLIP, then how your portal will change?
My portal goes more laterally. I'll start from the facet joint. Most lateral part of the facet joint, then will I usually put my finger in and then fill the facet completely, and then I make a working port enlarge. So you need to again, because bilaterally you have to do facet come in again from the same port. You need to put a screw. So I think Dr. Anindya has a UB relive case fusion. So I think we can have more discussion, that it is very important to discuss that.
Yes. So now we are burying on a contralateral side.
Yeah, contralateral bit, but my mission is to identify the midline.
Okay.
Enlarge the window a
Do you
bit.
prefer with doing the bony work, everything with burr, or do you use Carrison's?
No. I don't use Carrison till I remove the ligamentum flavum. Everything with the bone. Burr. And I expect there's a lot of bony work here, because if you see in the Siam, L45 window is very narrow.
So the motion of the burr should be continuously in a rotating
it's like,
manner.
Yeah, rotating manner. Now you see, now
Yes.
becoming my wind line become more evident, so that now I'm confident that I'm not ipsilateral too much or not a contralateral too much. Okay.
Yes, midline cleft is seen.
It's
Yes.
now started with seeing. Little bit here, because your scope is coming from this side, so it has to be comfortably seen.
Can you show the midline cleft, Dr. Bhupesh?
Yes, you see now. Nothing. Still, it's yet to see completely, but
Yes. It's at 11 o'clock.
yeah, it is. Yeah, it's till 11 o'clock. It's about to see. Little bit of more burring. Next few minutes we can see. You see now the change of flaval color. It become more whitish
Yes.
in the midline. You see now this is the midline. Okay. So, but we have to see the V junction
What is V junction?
So it is a bifurcation of the phloem. So once in the ipsilateral side, so it's yeah, now you see here. If you, I'll show you next few minutes. RF. So now we are seeing midline and we are doing preemptive coagulation. Okay, so that this bleeders doesn't bleed. This is very important to coagulate drill. So basically I am using 30-degree scope. So you always feel that you are doing more work on the ipsilateral side, but 30-degree scope showing more work on the contralateral side. So you are always end up with removing less bone on the our side. You see these are pars. So still there's a lot of thickness is remained in the pars.
So how do you decide how much lateral you would come?
Sir, I'll show you. I'll show you in next few minutes on the lateral margin. Because the change of ligamentum flaval color in ipsilateral facet, it becomes very much evident because it is a 4 degree scope, 4 mm scope.
As you talk about presumptive coagulation.
Preemptive, yeah.
Yeah, preemptive coagulation. So when you enter the scope, you are making the space. At that time also you can do in some areas.
Yes,
like that,
yes,
right?
yes. So I next moment when I'll start working lower part of the lamina, then again I'll do more little bit of coagulation so that some bleeders where I think we have one very good lecture on the talk and anatomy of the bleeders, how it seen in the epidural space, and what is the anatomy of that bleeder where it commonly comes out. We can easily make out.
Okay.
And we can easily do. And the RF. So I haven't used any instrument except drill and RF, nothing.
So you are trying to do end block. So do you
Yes.
think that you will need more bony removal in
Yes,
this case?
yes, end block,
Rather than
all the
just,
bony attachment of ligamentum flavum has to be drilled. Now I am going contralateral side, you see.
Yes.
So I see the midline now completely, so my orientation has be there. You see now midline completely, still we can expose more.
Okay. And if you have to go in a piecemeal, then when you will stop?
Piecemeal, still my approach will same. I'll do most of the bony work first, and till I find each edges, because whatever the part you have to drill, it is remove, it is remove. So once if you don't remove with the drill, you need to remove with the punch. So I feel the amount of the punch you insert in the epidural space, chances of bleeding and again chances of dural tear are higher.
Yes. So do the drilling first, and then
as
only
much as
start.
possible, yeah. So there is a bleeding, and we can control with the ablation mode. Okay, you see now. Bleeder
Yes.
point.
And you always
Sorry.
use protected bar?
Yeah, I use this hooded bar. સાહેબ આ બર સસ્તો છે એટલા માટે બીજા બધા ડાયમંડ વાળા મોંઘા આવે છે.
Cost effective.
Cost effective, most important is.
Yes.
Okay, so your burr is also, you can use as a dissector. So now I'm doing more of under the laminar work so that my instrument can move freely in ipsilateral as well as on the contralateral side.
Bhupesh bhai,
हाँ सर बोलो ने
what is the position? What is the position of light source with respect to your 30-degree scope?
position of light
Light
source
source
is in my
table.
I prefer to more on upper side.
You keep it 6 o'clock or 3 o'clock or 9 o'clock or
I
12 o'clock.
prefer to keep it around 11 to 12 o'clock. And I
11
always
to
believe
12.
we should be at the 6 o'clock position so that anytime you lost your orientation, with the V you can get your orientation back.
Yes, Bhupesh bhai, can you once orient again about midline cleft, medial,
Okay,
lateral,
I'll show
caudal
you, I'll
to
show
our
you.
delegates?
So this is the midline. You can see it at around 9 o'clock position. Can you see the epidural space, fat and everything? So here we have almost reached the upper part. You see now V junction is visible clearly. Can you see? So phlegm has been
That's the
detached.
midline cleft.
Okay, this is the midline. And now on the ipsilateral side, I just drill. Sir, Rakesh sir, this is answer.
Yes.
I go more, I'll put my scope little down and try to see the changes of ligamentum flavum color. It become more lighter. Still I need to drill the bone. So once he become lighter, then you can easily make out that your end block is ligamentum flavum is attachment to the SAP is near. I think Dr. Mahesha is there. He is master in removing the end block.
No, he is reaching in the OT.
Okay, he's just behind me. Okay.
Yeah, he will be joining you soon.
Sir, you have mic. You can elaborate more. Quadrant, yes. Left, here. Posterior, yeah. Yeah, here, at that side. Lower lamina also. So on my side, I have almost done now contralateral. So the beauty is 30-degree scope. You see, I rotate the scope here. Can you show here? My hand.
Yes, we can see that. Yes.
So that I can see my contralateral lamina. Contralateral lower part. Here you can clearly started seeing the changes of the ligamentum flavum color.
Dr. Bhupesh, this is Dr. Basu here.
Yes,
So आप
Basuji.
यहाँ पे do you want to use osteotome at some point here because
I use in the lower part.
going to
I'll show you. Here
Lower
if
part.
I need and then I use. You see now the color is changed. So attachment of ligamentum flavum is end here. So I'll do till lower lamina. I reach the lower lamina and then I lower laminar part work I do with separately. Okay. Okay, done. So contralateral, ipsilateral.
As well?
You see, give me curate. Sorry.
Are you planning to see the exiting route as well?
No, why?
Contralateral
But
exiting
yes,
route.
a little bit of SAP work I'll do because you see if in the MRI there is some amount of phlegm there is in the axilla. Curate, yeah. नहीं ये नहीं बीजू तू देवेंद्र
I think with this much of bone, you will definitely be able to see the exiting route right sided easily.
ના ના એ નહીં આપણું સેટઅપ નહીં યુબીના સેટમાં એંગલ ક્યુરેટ એ રહ્યું હા બસ ચલ so you see this curate this is a very
Beyond
beautiful
the-
instrument you can do majority of work with this curate it's around
Little bit, yes. So now the concept is midline is 3 midline. Midline, right midline and left midline. Will be almost like near the left.
so you see now
Spinous
contralaterally
process
I can see the phlegm is almost this is SAP on the contralateral side can you see and this is a facet joint
we can appreciate that you are trying to separate the
Phlegm from the
underneath
contralateral
the
SCP, yeah.
The curate is a very, very important instrument in the
Very
mammography.
important instrument, so that majority of work.
Curate is your life. In places where the Kirison can't reach, curate can help you.
Yeah.
Especially with 30-degree scope. I use a 0-degree scope. If you're using a 30-degree scope, there will be a lot of places where you'll be able to see them, but you can't reach them with your instrument.
So yes, this is the lower part.
आपको दिखेगा, पहुंच नहीं पाएंगे वहाँ.
Bhuvesh bhai,
So that is a useless thing. We cannot.
Saisa bhai is suggesting that you should use a 0 degree. Why you are using 30 degree?
क्यों?
Saisa bhai will answer.
30 डिग्री देखने के लिए अच्छा है, बहुत दिखता है, लेकिन वहाँ पे पहुंच नहीं पाते हैं.
कहाँ?
Even in bioportal, I think once you're accustomed using a 0 degree, it is very difficult to because as Dr. Anindya very rightly said, you'll be able to see things, but you will not be able to reach there. Even with biportal.
तो हमें तो पहुंच ही गया न बदे यार, नहीं पहुंचता क्या रही क्योंकि RF. So now I have finished both ipsilateral and contralateral side. Now I am moving to lower part. So
Plus, for the beginners also, it is very easy to start off with 0 degree.
And 0 degree gives you gives you the vision that your mind wants to see. It is exactly, you want to see a vision like this, a tunnel. 0 degree gives you that tunnel, and 30 degree gives you an extended tunnel. So the extension your mind is not trained to see initially. But yeah, once you cross this 20-30 cases mark, then you can do your one.
So this is phlegm which Dr. Mahesa was talking. You see now the lower attachment of the curate, attachment of the ligamentum phlegm to the lower lamina and space of the spinous process of the lower lamina. This you need to remove.
Are you planning to bury it or just with the curate?
I'll see.
Split?
I'll use the osteotomy here.
Okay.
Yeah, so this part in this patient, particular patient, this lower part is the ligamentum phlegm is very thick. It's a very narrow canal at that point.
So I'll again use the burr here just to make little space. Burr.
Exactly. So burying is very, very useful.
That's contralateral SCP you will burr, right?
Inferiorly.
What you are saying, કે vision જે સારું આવે. But in 30 degree we rotate કરીને we can have all the vision.
પણ તમારે end on જોવું તો તમે જોઈ ના શકો.
But whatever you want to see, તો એને rotate કરીને we can manage it.
Manage
RF.
One is initially it is very difficult for a new starter.
Orientation અને આવતા વાર લાગે.
Plus second thing, જે first initial
curate.
That is more than 30 degree.
30 degree, okay.
That is less than
એટલે એ પેલા હું દેખાતો થઈ ગયો.
You can actually see the corners more faster than you. Once you are experienced enough, you can definitely all that. But in fact, definitely some extra work for 30 degrees. If you have better view inside the light expertise, for this stage of fibrosis. This is a fibrosis. You need a monoportal and which are suits you, I think. No, I'm asking about the fibrosis. Achha, okay. Monoportal maybe is more meaningful.
No, yeah, I think extent of fibrosis is less with monoportal, more with biportal. I had a discussion with Dr. Mahesh. He revised few of biportal, suggesting he found a lot of fibrosis.
It's all about the technique, sir. It's all about the technique. Even biportal can be made very, very less traumatic if you by certain technique. So there is Dr. Son's idea of how to reduce tissue damage in biportal. If possible, we'll talk about it.
Curate now.
it will be operator dependent as well.
Absolutely.
To certain extent, procedure both. I think procedure also is very nice. Inherently, I told you, I told you more, but still, surgery. Maybe. And patient dependent as well. Patient with a tendency of fibrosis is also another.
ये में आ रहे हैं then osteo. चीज़ लग रही है.
So now you are working on a caudal side.
Caudal side, yes, completely on the caudal side. So I separate the ligamentum fleum of the below lamina, and now I move to the caudal side completely. Okay.
Okay. Which plasma system is this?
This is कौन सी system है आरिफ ने यहाँ? This is the Korean one. भूली गई है.
Bones.
नहीं eloquence नहीं.
Endovision.
Endovision, yes. Sorry यार भूली. चलो hammer.
I saw that in the morning.
Hammer. So I use this osteotomy and chisel in the lower lamina because chisel.
That's ipsilateral lower lamina.
Lamina, yes, and okay. Contralateral. Ipsilateral and contralateral on the base. Okay. So don't break completely. Just break the outer cortex and use the chisel. And then now contralateral, okay? Hammer. So here the stenosis is more in the lower part, so I remove little bit of more part of this lamina. Both. Okay, now you see the dura? Hello?
Yes, yeah, we can see. So you reach below the level of ligamentum fleum attachment.
Yes, with the ostrom.
Very nice. Have you ever encountered dural tear while doing this step?
No, never. I think अभी तक तो नहीं हुआ है सर. बोलना भी नहीं है. Hammer.
I think if you are using a curved osteotomy device, it's just like the difference between spinal needle and then.
So I am just going more.
Yes. Even if it hits because you're at an angle, the dura will be hit by the blunt.
Good part of endoscopy is like if you open the canal at any point, the fluid pressure will
Push the dura down.
Yeah. It keeps clear or this curate along the margins.
Yeah, right.
चलो curate. बोल. उस पर पड़ेंगे. So this is the bone which I osteotomized. Carry some bone. Also this close. चलो curate. So now on the contralateral side, I just do and again with the sleeve okay, you see now with the sleeve I just retracted. Oh, sorry. So carry some. Carry some. This forceps. This part takes little time.
We were just discussing end block removal takes more time than piece movement.
Yes, definitely. Curate. So now we almost separate the lower part of the lamina from the phlegm के ostium दे थोड़ा. Drill दे दे. आरएफ ओछू करना बेटा.
What is the setting that you're
Now I am doing
keeping?
2-2. Initially I used 4 and 3. So you see the contralateral phlegm. I'm just below the contralateral phlegm just to see whether I'm not there is no adhesion. So now I'll identify the margin and go below that contralateral phlegm and separate it. This is on opposite side. So separate it out. And once I separate down, then go upside. Yeah. So now it is separated from upper level, upper lamina. Carry son. कौन है? पति हो रहा था ना आपके पास. अरे पीछे जाइए. इसको समझिए. अरे यार इसका आधा फ्लेम आ गया. With that bony attachment, that phlegm comes down. Curate. Contralateral phlegm was come in hemi phlebectomy. So this is only little bit part of the phlegm that has remained.
So it's in a 2 parts now.
Yeah. So lower bony part we remove that has flaval attachment. So entire phlegm was separated. So it comes out. So this is a foraminal extension. We have drilled a bit. Dispose it. Garrison. મોટું નાના પ્લોટનું 3 mm આવે 4 mm પ્લોટ. અઢીવાળો આપને ક્યુરેટ નહીં मुझे क्यूरेट एक अच्छा को सबसे गया इसको अच्छा इसको सबसे होने में मुझे पता नहीं है. So this is SAP and IAP junction. Hello.
Yes.
This is a SAP and IAP junction.
Yes, yes, we can appreciate it.
Yeah. So Garrison ठीक आप यार.
So now you are working on ipsilateral side.
पानी खत्म हो गया. कौन सो गया?
So do you find the use of rotating Cadcon here?
No. अपना अच्छा ब्रांडेड फोर्सेस बहुत अच्छा काम लग जाता है यहाँ.
And Dr. Bhupesh, as you do both monoportal and biportal, what is your take on saline use?
Saline use monoportal, less saline use. Biportal use more of saline. But
So-
I think that is because of free flow.
Yes, yes. So for a single level decompression in a monoportal, how much bottle?
I use around 2 to 3 bottle in monoportal. Biportal around
And in
4 bottle.
How much?
For 4 bottle in biportal.
Okay. Yes.
एक बॉटल ज़्यादा यूज होता है, कभी बार 2 भी होता है.
So you are nearby. Otherwise, biportal में बहुत ज़्यादा होता है.
चलो क्यूरेट.
टीमेट रखा है क्या कर लेते नहीं तो मतलब सलाइन यूज कम होता है इन्फेक्शन रेट.
So I am just tracing the media SAP upward. You see now this is SAP. Can you see? Okay, so we remove ipsilateral phlegm. So this is a SAP and attached phlegm. Okay, so it ensures that your medial decompression is
Okay.
good.
So you will go till you can see the lateral
Recess, yeah.
part of the root.
Yes. You can see lateral recess now.
Yes.
This is the lateral recess, okay? Disc forceps अच्छा होगा. RF. Space and remove the flavor.
Okay.
Comparison. अरे पानी पતી ગયું એવું છે.
So Bhupesh, you do multi-level bipodal. How much maximum irrigation have you used, or how much is your limit?
सर
At what
14
point
बॉटल
you
अब तक यूज किए हमने. Around 14
bottle is-
bottles. 14. But sir, if you see, okay, here the advantage of bipodal here, the irrigation easily comes out. So whenever we put the instrument, even though irrigation flows continues, because our incision is larger than irrigation.
True, but there would be some amount that would be absorbing. So that's why at what point you would say, I would do
I
second
have
stage.
done 3 level, not more than 3 level. Around even in fusion we usually use around 11 to 12 saline.
No, I have done up to 5 level. So nothing happened.
Yeah.
Okay. And how much is irrigation used?
Irrigation we use less, maybe 5 level may take 10 bottles.
10 bottles, circa.
Yeah, so not a problem. And also all these cases I have done under spinal, so any pressure effects patient will tell me.
So what is your take on using the pressure pump?
Initial cases I had used pressure pump, but I few patients I did get post-operative complication and I couldn't find any reason, so then I stopped using irrigation.
So what kind of complication you find?
Like one patient came from Zambia to get operated, a young patient with a lumbar disc herniation with a stenosis, not too bad. So moderate stenosis with lumbar L4-5 disc herniation.
Okay.
Post-op bilateral foot drop.
Okay.
And when I watched the video, I did not see that there was any, apart from irrigation pump, I could not find any other reason. So
Okay.
that since then I used gravity based following Mahesha.
I have never used irrigation pump because I don't know.
No, I have used pump in Cairo. Whenever you use pressure more than 50, it causes problems. I have seen patients developing transient deficit post-op if the pressure is more.
Okay.
But it recovers, but we don't want this problem.
It recovered at 6 weeks, but then till then.
Headache.
It's headache for a surgeon.
Yeah, you explain to the patient that you will go home next day, you can fly back 3 weeks. Then
तब तक बहुत लोगों ने जान लिया होता है उसको कुछ हो गया curate. So this corner is sometimes tricky. So you use.
It's application, how they take it, that's the most important.
Even in shoulder, many surgeons have stopped using irrigation
Yes.
because it causes problems.
वो डायरेक्शन हाइपोनेट्री में हो जाता है काफ़ी बार उससे. चलो फोर्सेप्स. So I'm about to finish, just cleaning the. सर आप वॉश हो जाओ.
हाँ मैं वॉश करता हूँ. वो थोड़ा उनका वीडियो बाकी है.
हाँ
वो वीडियो बाकी है, वो खत्म करने के टाइम में हम ये.
ओके ओके ओके.
राकेश का प्रेजेंटेशन थोड़ा.
यस यस विल फिनिश इट. I am very poor in cleaning this,
ये तो बहुत
उसके साथ ये साला
आपका
इतना
हो
गोल-गोल-
गया सर.
हाँ
चाय कॉफी पियो, पेशेंट मिल जाएगा पेशेंट.
अरे
सर्जरी इज डन, लुक ब्यूटीफुल.
एक मिनट थोड़ा और थोड़ा कर देते हैं, चाय पी लेते हैं.
We don't need to decompress intradural. Extradural is already done.
ओके थोड़ा कॉन्ट्रालेटरल और कुछ नहीं. आई एम नॉट हैप्पी टिल कॉन्ट्रालेटरल बिकॉज देयर इज समथिंग हियर.
You're working on the disc ना there.
या
हाँ, so that is done ना.
नहीं थोड़ा भी रूट फ्री नहीं हुआ है.
थोड़ा
We can appreciate the root. Yeah.
ये वाला पार्ट निकलना चाहिए. हाँ because ipsilateral we do laminotomy, contralateral we just do under the cut, na? So if the root is not completely free there, if you cannot see the pedicle, our decompression may not be complete. अरे हंसो नहीं, શું થયું બોલો.
પેશમેકર તો પેશન્ટના આ જન્મનું પતી ગયું, તમે નેક્સ્ટ જન્મનું ડીકમ્પ્રેસ કરો.
ના 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 થઈ ગયું ચલો. ચલો डिसेक्टर okay now
So Bhupesh, you use general anesthesia or epidural?
general. This patient is under general because we need to do 3 level, na?
Okay.
Otherwise 2 level I would do.
So 3 level, are you using different techniques now?
No.
Like next monoportal?
Yes, now we will use the monoportal.
Okay.
So that so this is the angle forceps Cadcon. Most medial angle when we are not normal conventional Cadcon cannot do this. This can do easily. સાહેબ તમારું કંઈક 10 મિનિટનું બાકી છે ને હજી ટોક કંઈ રાકેશભાઈ
Yes.
એ ફિનિશ કરી મહેતા સાહેબનું કહેવાનું એવું થાય છે. So now it's complete. Okay. So give me I am just orient ourselves to the final picture. So this is a L4 L5 severe canal stenosis. We did a biportal endoscopy and this is a disc. This is a root completely free. You can see the axilla also on the ipsilateral side. Go to the contralateral side. Here contralaterally we see the disc completely and we did adequate decompression and we can feel the pedicle. You see the pedicle here in the contralateral side. Can you see the pedicle? Yes. So pedicle to pedicle decompression should be there for the stenosis. So root is now exiting from the contralateral pedicle, below the contralateral pedicle. Okay. Thank you.
Yeah. Well done. So big round of applause for Bhupesh for demonstrating excellent.
Very nice demonstration.
Any question? Anyone else?
Any question if you have?
So are you going to do something for the disc?
No, I'll not do anything for the disc because it's a pure root is completely free. You know, see now it becomes free. हाँ बोलो रोहित भाई.
Have you ever tried this surgery from right side?
No.
It is very similar way you can do this.
Yes,
It's
we
the
can.
same thing.
But I have not tried.
Right से भी आज वस्तु चाहिए.
How to do that?
They do from right. Am I right? नहीं ले. Same way.
You stand on left side.
Thank you, Bhupesh bhai.
Thank
So
you,
now we are
thank you.
continuing with
Monoportal at L34. Dr. Mahesha will do monoportal surgery L34 so that we can have a demonstration of all the different endoscopic techniques. Okay?
yes, yes, we are continuing with
Yes, Dr.
Dr.
Rakesh Lohana's lecture.
presentation.
Yeah.
Yes, yeah.
ये क्या है ये क्या है
એ પેલા આજે છે ને ઘણી વખત એવું થાય કે આ બોન છે ને એ બોન તમે રિમૂવ કરતા આવી જાય પ્લેમાં જઈ જાય
हमें lateral चाहिए और टू नीड
ના ધીરે થોડી શાંતિ લીધે આપો adequacy of decompression become very good.
lateral
બ્લીડિંગ થાય છે માર્ક કરી so go back to the MRI. Can you show this the MRI? Light chal karo. So you see now there is a L3, L4 lateral recess stenosis, lumbar canal stenosis here.
dilator cannula
Okay. Oh, they all but these.
CSLD से निकाल
So we are using this biportal instrument from the Jason Surgical. So this is a very good instrument set and dilators and everything is good. Drill system we use the Striker and Endovision RF. Okay. So now I have kept one very good things for Dr. Mahesha. This Om Surgical RF.
okay we'll see whether it works
So you see, can you see the MRI? Hello.
Yes.
Yeah.
Now we are seeing it.
Yeah, the L3-4 level we are going to do decompression. L4-5 we finished and L2-3 we'll do if we have time. After that we will have a lunch. After lunch we will do a cervical 2-level posterior cervical endoscopic decompression. And the last is 3-level transcam infusion. So total 5 cases we have planned today. Let's see how much time it takes. So ये नहीं वो नहीं चाहिए भूली तू वस्तु है ना भूली गए थे नहीं वो भी
So Bhupesh, till you set up, we finished that relive. We'll catch you again.
एक और नीड ही चाहिए
Okay, so that was an excellent demonstration, and now we'll come back here. So
सर थोड़ा हार्ड जाएगा पर हो जाएगा इतना वो थोड़ा बेंड हो गया वो तो खाली बदलिया છે આપણે જેમાં કમ્ફર્ટેબલ નહીં બીજાને આપવાનું
lateral decompression being done. Contralateral lateral recess, decompression, and contralateral forearm anatomy.
ब्रदर लेडे खड़े हो जाओ
So you can see the fat lateral to the traversing root,
थोड़ा ऊपर ले
and then you follow the root and do a forearm anatomy.
ठीक है ठीक एक मिनट एक और नीड चाहिए एक मिनट वेट एक और नीड चाहिए
They will do PCL for a internal resection. I think need more patience. So when you begin, keep ample time aside and keep patience, and then gradually you would cross your learning curve, beginning with a simple disc, then ipsilateral stenosis, then going over the top, choosing wide canal to stenosis, then going to severe stenosis. Trying to jump that learning curve, you may end up getting some complication, and that would kill your enthusiasm. So it's important that you avoid complication and cross your learning curve gradually. So that's a contralateral root, L5 root. That's reaching to the inferior border. So that's plasma. So that's a central canal, that's ipsilateral traversing root, and that's a axilla and bearing endpoint. That's seeing contralateral. The advantage of using RF is you can coagulate even on the root, but use a pulse coagulation and avoid continuous coagulation.
Ever encountered?
So post-epidural patient would have, as developed paresthesia laterally, you might think that there is cerebral injury, but as such, yeah, it's difficult to
delineate what it is.
Yes.
But no motor.
This was the one patient I said, one patient had a foot drop. I thought it was due to irrigation rather than a
you used pump.
Pump, yeah. Probably that. I think when if you're using pump, it's important to get a good quality pump. I was using one Indian company pump where I guess it was showing something and then delivering something. When I look out outside, it was like literally with that, and it was the pressure demonstrated on the screen was very less. So probably that was the reason. So the closer post-operative protocol is use 3 doses of IV antibiotics, high seating ambulation same day, climbing stairs and discharge next day, and suture removal at 10 days. So that's pre-op and post-op. That's pre-op stenosis, and you can see post-op very good decompression there and axial touch showing. So that you can see the path over the top decompression, ipsilateral, bilateral, adequate decompression. And that's what CT would show. We preserved pars, preserved facet. That's what the bony window is. Then you get adequate decompression. So learning points, study preoperative MRI and X-rays carefully. Divide into 4 compartments and follow pattern, ipsilateral upper, hip lower, contralateral upper quadrant and contralateral lower quadrant. And preserve ligamentum, fleum, tibial bony work is complete. And in initial cases, get post-op MRI. It will help you get better. You begin with simple single level. So I shall ask questions. So, once you start finishing single level in 1 hour, 1 hour 15 minutes, then you go to 2 level and 3 or more level. I think you should be finishing 1 level in maybe 45 minutes. Then only you should go, or better you can stage it. And yes, there may be some complication. It is difficult to cross that learning curve, but don't get disheartened by initial struggles. Every expert was once a beginner. Thank you.
Thank you, sir.
Time 24. 24 hours or delay. Means second, third day, then you may see some collection, some edema. So better either you get very next day or sorry, either you get very next day MRI or at 3 months. Yeah. Previous night, sorry. शायद ये changed. आज ये वाला अच्छा so fellowship at our center is short term and long term. It is valid by MISAB as well as of somebody's neurosurgeon, Neurospine Association as well. Short term is 3 weeks to 3 months and long term is 1 year to 2 years. And we do predominantly endoscopy and MIS and CV junction as well if some neurosurgeons are there. We do around 50-60 cases a month. So even if you come for 3 weeks to 1 month or 3 months, it would be good for beginner. Thank you.
Thank you, Rakesh sir. It was a wonderful presentation. Now we will shift to the OR. Dr. Mahesa. Dr. Mahesa. Dr. Bhupesh.
Yes, हो गया. अभी sir बोलो.
Hello? Yeah, can you hear me?
Yes. Now we can hear.
You can hear?
Yes.
Hello?
Yes.
You're able to hear? Okay. Okay, so we are doing the L3-4 level now. Can you show the
Okay.
Siam picture once? Garrison?
Siam picture. Vatan.
So we have marked the, no, just focus. So I take just one Siam shot, just to mark. So after that, we don't require Siam. No triangulation, nothing. Just docking.
Okay. Just to confirm the level.
Just docking, finished. I don't even wear lead apron. We don't require Siam anymore. Okay. So we take one AP and lateral views, so you can confirm the level. I hope you can appreciate that. So we have just cleared the, in the AP lateral, can you see in the Siam? Hello? Curate?
Mahisha, you are docking 2 levels simultaneously or what?
Yeah, 2 level. I take only one Siam shot. I don't require multiple. So after this, I don't take any more shots. I will do one confirmatory Siam at the end of the procedure, just to see my bone work. That's it.
So for beginner, it is important to take. I would suggest that making a protocol, taking a Siam shot initially, and once you do soft tissue work before beginning bony work, I think once again confirm. It is very important. I have seen wrong level being done in endoscopy. So it's important. that this is one gross negligence that cannot be defended wrong level. So it's very, very important to prevent wrong level in any modality of surgery, whether you do endoscopy, MIS, or open. Mahesha is one of the leading experts across the country with excellent surgical hands, high level of confidence, and he can experiment newer techniques, modality, very courageous surgeon. So many things to learn, but keeping protocol is important
Yeah,
for
my
beginner.
protocol is I take one CM shot the end to confirm, finished. So I don't miss the level.
Yeah, yeah.
Yes, I very much agree with you. It's very important to not miss the level. And sometimes as an endoscopic surgeon, initially, if you realize after 1 hour into surgery that you are doing the wrong level, very frustrating. So it is always better to have
So recently that happened to me. This protocol we have changed just last month. My fellow was exposing, so I allow them to expose and then I join. So there is one CM shot he exposed and I started working on it. My anesthetist friend I was operating on, he was there. I struggled for half an hour. That angle was not proper, so I said let's check a reshoot, and we were at wrong.
Yes,
So,
yes. I
so
very much
now-
agree with you, and that's why the protocol should be followed initially, at least till you are confident enough.
Parth was operating in Raipur, and he did the mastectomy, and then realized that he was operating on the wrong.
So yes, any that can happen at any level. So it's important to
Unnecessary extension of the surgery.
Yeah, yeah.
In a mild sleep also in the cage in a completely wrong way.
Yes, it can happen. Yes, yes.
And those things depend in part of. So then it all depends on patient's related also.
Yes, yes, yes. And how you tackle at that time. How you explain that.
So there is no explanation to operating the wrong level.
If we come to know intraoperatively, then still it can be managed. But once the patient is out of OR, then it is difficult.
Come to know next day.
You can do nothing.
Okay. Hello. Hello.
Mahesha,
Yeah.
how have you managed a spotless field?
Yeah. That is the technique we have to master. So you can see the whole lamina now, and this is the pars here. Can you see the pars here? This is my
Yes.
lighthouse. So once I have enough bone here, I can drill anything that is medial to it. Okay. So this is the facet joint, and this is the interlaminar window, and this is the lower lamina. So before you start any bony work, all these landmarks you have to be very, very clear. So unless this field is very clear, I will not start any drilling. Okay. So if you follow the steps very carefully, then rest of the steps becomes easier. Okay. So this is the medial edge of the facet joint. So we start at the spinolaminar junction. Now I am using a cutting burr. Acha hai. So initial drilling we use cutting burr.
So this is real time or you have make it 2x?
No, this is real time, no 2x.
Fantastic.
So
have you adrenaline in the irrigation fluid here?
Yes. So Rakesh, regarding your point, it is very difficult to train young people because they make all mistakes and then you have to start correcting them.
Yeah.
So when you have fellows, you make, you realize all these things.
Yeah, true. Agree.
Because they will go with odd angles, they may mark long level, everything will happen.
Yeah.
They will cause a tear, then you have to manage it.
But passing on skills is equally important, right?
Yeah, that
Mahesh?
is
You have to
important. So because it is part and parcel of our
part and parcel, right? You
so
grow
there is-
along.
आपके पास वो ओवल है ना, वो दे दो. नहीं, oval burr. So once the cancellous bone is exposed, there will be some bleeding. So we can use drill to remove soft tissue also, which is coming in the way. Okay. So pars is here, so I know how much I am going. Change the
So
burr
please
to-
read again, Mahisha.
Yeah.
Where is
now
your
I am on the left side. So 9 o'clock is cranial. 3 o'clock is caudal. You can see the flavum there, and 12 is medial, and 6 is lateral. So this is the pars. How much pars is still here? Can you see?
Yes.
So
Yes, yeah.
this cannula is 10 millimeters. So if you
Yeah.
have about 5 millimeter, it is okay. If you want, you can extend more. And one advantage of this 10 mm cannula is if you are able to get the cannula inside your bony window, that means it is good decompression.
Okay. Yeah.
So this is not possible with the rivoscope currently, because they have bigger one. Their cannula is 11 millimeters. So I changed the burr to the less aggressive one. So this is a oval shaped burr. So this will control the bleeding also.
Diamond burr.
It is not a diamond burr. I think it is a coarse burr.
Okay. Coarse diamond kind of. Yeah.
Coarse cutting maybe.
Okay.
So can you see the flavum now in the depth?
Yeah.
So we have to go up till we see the cranial attachment. Usually the cranial attachment is more proximal on the lateral side. So you can see the medially there is already getting released. You can use diamond burr if the bleeding is troublesome.
Oh, Mahisha, average time taken to do a single level stenosis for in your hands at your setup?
It depends on many things. So if I am relaxed and teaching some youngsters, I may take 1 hour. If I have to do 3 levels, I will do faster. I can do it in 20 minutes also in my setup. So time varies.
Yeah.
So you see the pars here. This is
Just discussing about time, but just for those who are getting into the surgery,
yeah,
time.
you see already
Time is not
Garrison,
the criteria.
time is not the criteria.
Absolutely.
Can you give me a diamond burr? नहीं diamond use करते हैं वो bone bleeding है.
Just asking because seeing excellent control and speed of the drill, I think he may be able to finish faster.
ठीक है diamond use करते हैं एक बार. Let us see. When there is bone bleeding, just sorry, diamond burr. This is another burr, I think. Which is the burr? This? Jishan's burr.
But usually 1 ampule in 1 bottle.
Rakesh, you are using it? Give me the other one, ablator.
How much adrenaline is put in one bottle?
1 ampule in 1 bottle. Press. Which is one? Ablation. There are many foot switch here, so I don't know what is what. Ablation. So if the bleeding is still not controlled, we can use bone wax. So I can tell you that this ablator, which is particularly used, it is very high energy. So I think same thing is used in UB. So I can actually feel the hot saline which is coming out, which I never see even in when I use monopolar. So that's why maybe these things can cause a lot of fibrosis. So still it is bone oozing. Can you give some wax? नहीं वो bone bleeding है. Give नहीं ablator there. एक पर ablator there. तो ठीक है.
So is it comfortable using side firing RF plasma or
No,
deep fire?
I am very comfortable with the monopolar and RF. I don't use these things. It is still losing. Do you have bone wax? Bone wax, because this is spoiling the field. So we'll just put some bone wax, it will settle down.
So to control bleeding from bone, either one can use diamond burr, one can use bone wax.
No, it is not good.
So last option is bone wax.
Reverse cutting drill is also an option, and one can use
Bone wax
inst-
curate के पीछे डालो.
press over it. Even tip of Cadcon can be used. To learn endoscopy, two things are very important. One is mastering hemostasis, and second thing is mastering drilling. These two things are very, very important. So please focus on how both are being done.
And most important thing is patience. You should have patience, because sometimes things don't go in your way. Still you have to continue the surgery. थोड़ा wax और दे दो.
I think for a spine surgery, whatever modality you use, be it open, MIS or endo, patience becomes very, very important for any surgery, I guess.
Hello. So this kind of scenario, you can use the blunt end of the Cadcon punch to crush that bone. We tried initially with the diamond burr, but not controlling. Then RF ablation mode, still not controlling. The last one is this bone wax.
Tip में डालो. Tip में. I have a separate instrument which will deliver the wax, but here we don't have it.
Yeah.
So what happens is when you load it over the curate, it gets stuck
in the working channel.
Channel. So
what kind of instrument it is, Mahesha, for bone wax?
It is a separate. Now I am using curate, but I have a separate bone wax delivery instrument. You see, now it is controlled. If I crush with the Cadcon, no, it will still start oozing, because she is highly porotic.
Yeah, bone is very porotic.
Bone is very porotic. If the bone is reasonably strong, we can still crush it. So it's okay now. Okay.
Yeah.
So this is very important, to have a clear field. Cadcon. So my cranial and lateral extent is okay. So I don't think I have to go anything more. See, already it is released.
End of the flavor.
Yeah. So that is the end of the flavor. Okay. So can you give the burr? So I have to go to the lateral part. Yeah. Or you can use a osteotome also. Give the osteotome.
Osteotome भी दे अपने.
Osteotome मेरा set में है. ठीक है. So we can use a osteotome here. If you see here, this is the pars. So we have about 4 millimeter bone there. That is fine. And this is the ipsilateral facet. Hit.
So this is a chisel.
Hit.
Yeah, hit hard.
Hard. Okay, so it broke. Hit again. Hit. Okay, she's very, very porotic. Hit. Okay, so we have broken the ipsilateral facet.
So medial facet
grasper.
Yeah.
You just have to release the phloem attachment and then take it out.
Yeah.
Okay. Yeah. Only disadvantage is it can cause some bleeding. So normally it will come as one piece, but here because she is porotic, it's broken into multiple pieces. नहीं नहीं ग्राफ्टर नहीं ग्राफ्टर टूट गया गिव अनदर ग्राफ्टर मेरा सेट दे दो so once you control the bleeding you see it is very clear so any questions
hello
yes sir
Yeah.
અલે સુઈ નથી ગયા ને
ના બધા lost in watching.
so you will try to remove the ligamentum flavum and block
if it comes it is okay otherwise it's okay doesn't matter
okay
so thoda bar de do. So we have removed this ipsilateral.
Contralateral needs to be done.
We will have to go contralateral. Sorry, where is the burr foot switch? We have two different burrs. So if you see my cannula is going in now, okay? So that means
yes.
ipsilateral decompression is good enough.
You have luxury today, no?
No, it is become problem. It's like selection of Indian team. Don't know which to use. Give me the oval burr. I don't know which foot switch is where. Give me the burr. Whether to take Vaibhav or Abhishek or Ishan Kishan or Gil or we don't know. Okay. So I'm going to the opposite side now.
आपने भेजा रिपोर्ट तो ठीक है अच्छा है
Give me a curate. So curate is a very good instrument. So we just have to peel the flavum from here. Give me the burr. Can you see the other side attachment? Yeah. Thoda clean.
Yes, we can appreciate that.
Yeah. You just have to clear this bone. Give me 1 minute. Hold this. Give me the kerosene 2 ml.
Okay, so then you will be working on the caudal side.
Yeah. Give me the burr. So I am just rotating my scope and cannula by 90 degrees so that I can see the other side.
Okay, so this is on a 9 o'clock is the contralateral side.
Yes. 6 to 12 o'clock is contralateral.
I just rotated
12 o'clock is a caudal, 9 o'clock is a contralateral side.
I just rotated my scope and cannula so that I
Okay.
can see the other side clearly. By 90 degrees I have rotated.
Okay.
Okay, so you can see the other side now. Only this base of the spinous process I have to drill. So phloem will protect your neural elements, so that is one advantage, keeping the phloem, and also it doesn't bleed much.
Yes, epidural bleeding is also prevented.
Yeah. एक क्यूरेट मेरा सेट में है बड़ा वाला, वो दे दो. हाँ सेम ही है. हाँ दे दो. नहीं करुड़ दे. हाँ वो दे दो. So you can actually peel the phloem very nicely here.
Yes, yes.
So whole phloem you can peel it off. So there's a contralateral side, cranial attachment. So that we have peeled now. Peel it out, and just the lower attachment you have to see. So this is the contralateral facet. Can you see?
Yes, yes.
So
We can appreciate.
Yeah, that is the contralateral facet. The ascending facet. Okay.
Okay.
Can you see? So that is the contralateral ascending facet. So here I have to do some more drilling here. But
So on what RPM you are using this drill right now?
I don't know, because 9,000. Okay, because I am using this burr first time. This is a striker,
Okay.
so it's working with striker. So striker is any 9,000 only. Okay,
Okay.
burr.
Mahisha, does separating the two layers of phloem make it easier to remove it?
You can separate it, so but you can do it without also. So caudally here I have some soft tissue which I have to clear. Cutter.
हेलो हाँ बोलो.
So this is the tip of the facet, some capsule, some cutting. Correct?
हाँ हाँ ready कराओ.
So now I take out the superficial attachment to the lower lamina. Okay. So that I can drill the lower lamina clearly. Carrison. हाँ, this is the superficial attachment. हाँ. Grasper. So I need to see the lower lamina to drill. So this is a superficial attachment Dr. Kavi was talking about. Harrison, can you see?
Yes, superficial layer of the phloem is out.
Yeah. So once we release it, we can see the lower lamina very clearly.
Yeah, it delineates the bone margins very clearly.
And we can drill the lower lamina. So can you appreciate the lower lamina now?
Yes.
Cutter. That is the lower laminotomy. Okay. That is
Yes.
the lower level. So again, you can confirm that it is the correct level without CM. Okay.
Yes.
So there are ways how you can confirm the levels. Okay, burr. So this is lower lamina. Can you see? So
Yes, yes.
yeah,
Yes, yes, we can appreciate.
yeah. So again we do the drilling here. Yeah, अच्छा है. You can use kerosene also. Here stenosis is not much, like 4-5. So we can safely use kerosene here. Clean. So here it is already open. Can you see? Give me the kerosene. So
Yes.
kerosene. So go close to the bone and then take it out. And always under vision. Kerosene. So that is the flavum. नहीं चलेगा. Yeah, that's good. But only thing is length is bit more. Yeah. आपके पास टिप RF है? RF. Okay, you can see the whole dural sac. Give me a dissector. I'll just check where is the root now.
Okay. So you have opened it from caudal side.
Caudal side, yes. आपके पास curve dissector है? Give me kerosene. हाँ, kerosene, kerosene. Kerosene दे दो. Kerosene. Dissector curved है आपके पास. So you can already see the facet there. ठीक है, kerosene दे दो. हाँ, correct. I am conservative with the facet work. If required, I will do more later. Initially, I will not take out all the facet. Okay. Dissector, you see the lateral side is already released. Dissector है. So lateral side of the flavum is released. This is the facet.
Yes, we can appreciate that.
Yeah. Give me the kerosene. हाँ, पीरियड से हो सकता है, होता है, थोड़ा ये बोन निकलता है. केरिसन. हाँ, ओके. So upper levels you have to be careful with the facet resection because very easily you can damage or fracture the facet. Okay, curate.
So,
you
where is
can-
your control limit? How do you decide that control facet is being damaged, or how do you come to know? How do you prevent that?
Uh, you will see if the facet is moving, that means you are fractured.
Yeah, but right?
You should not see that.
डैमेज हो गया तो क्या ही करेगा भाई?
No, just leave it, because even if you break one facet, still patient may not have instability in all cases.
Yeah, true. हायर लेवल इप्सिलेटरल तो काफी बार जाता ही होगा.
It is such a minimally technique that the bony work done of in even partial consideration one side.
Yeah, that should be well tolerated actually. Your spinous process is that control.
You're not opening the annulus.
Okay.
And these kind of ligaments and all these things.
Sir.
True.
Okay, curate.
The thing is, because of the magnification,
So you can see the root here. Can you see? So the root is going there. There is some bone attachment. It's okay. Problem.
cutting less bones than what you intend. Both of these endoscopies.
So this is the cranial attachment.
Endoscopically, iatrogenic instability, endoscopically, I doubt anyone would have done that. Pars fracture.
Possible.
Would be less incidence.
Less.
Never send surgery.
Anything can happen.
Okay.
We do less than normal.
बड़ा वाला. So phleom, you see, is already split, so I don't think it will come en bloc. Okay, बड़ा वाला.
We shot more of inadequately.
बड़ा वाला. एक और है ना?
You already have butterflies in the stomach.
ये छोटा है. 3 mm 4 mm है. वो मेरा सेट में एक है. दे दो. हाँ. ये नहीं जा रहा. नहीं जा रहा. ये ठीक है. या. ठीक. So this is the ipsilateral side, lateral recess. Clean. Okay. Yeah. Curate. Okay, this side is free. Yeah. So, Kerrison. So, this is the contralateral side. This is the midline, and we are going to the contralateral side. Okay. Give me the burr or Kerrison. So, you can use Kerrison, burr, or osteotome, whatever. Okay. Okay. No. No, I was telling you can use anything. So, semi-phleum is out already. So, Kerrison, small. So, you can see the opposite side now. Can you see the opposite side?
Yes.
Yes, yeah, we are seeing it well.
Yeah. This is the facet, opposite side.
Yeah.
You see, whole thing is free now. Curate. You can see the opposite root also. Curate. Cut.
Yeah.
So this is the cranial, I mean posterior attachment. Can you see at the top?
Hmm.
So this side out whether it will come en bloc because it's already split in midline. But anyway, we will see. So this is the posterior attachment which I am going to release. Mm. Correct. So we have released cranially caudally, and this is the contralateral side, which is free now, and here it is free.
Yes, it's free from cranial side.
Yes. Give me a grasper. I'll just clear this fat to see the other side.
So what will be your endpoint? You see both the roots and
Yes, yes. Both roots we have to see.
okay.
Give me the curate. Hmm.
EMI પસંદ મેં ચાલુ આ એક બંધ કરો એટલે તમારો ખુદ બી આવે ચાલુ થાય
હપ્તાની જિંદગી હપ્તામાં
હપ્તામાં બચી જવાની છે બરોબર છે.
Okay, give me the grasper. Let us see if it comes now. हाँ देखते हैं. Cutter एक बार. Yeah.
Cutter.
He accepts it on the top.
कुछ चलता ही रहेगा.
Carison. Small.
But everything is
Grasper. So the phloem is free now. It is freely floating. Okay. So we will pick it up.
Okay, so you will just take it out now.
Yeah. It may come as split pieces. So let us see. So one big chunk is come out. So
Okay, so you will take the sleeve out also all the time?
Yeah, if the whole phloem comes, you have to take out the sleeve. Grasper.
Okay.
It will not come without taking out the sleeve because it will be too big. Carison. बड़ा वाला. So
that is a bit of lateral,
bit of phloem is remaining in the lateral recess. Once we clear that, it is done. Saline खाली हो गया. Just increase the height. Saline. बड़ा वाला दे दो. बड़ा big.
પર જે કમ્ફર્ટ ઝોન આવી ગયો ને પછી આમ બહુ ચેન્જ કરવાની ચાલે છે તો બરોબર છે time drastic difference ઉપર અને drastic difference yeah then we can try it yes drastic change yeah recent advance બહુ બધું હા કોસ્ટ ઇફેક્ટિવ બી થયું એ જ કહું છું કે કોસ્ટ ઇફેક્ટિવ થયું affordable થયું cost effective થયું and that's why we can use it બરોબર
So you can see the root here. Okay. So what I do is I go inside, push the root away, and then take the bite. Okay.
Yes. So it is lateral recess decompression.
Yeah, it is fully decompressed this side.
Okay.
On my side, the scope, the vision is bit unclear. I think it is something to do with the scope as such.
Okay.
But we get clearer picture than this. So small correction. So just I have to remove this lateral recess phleum on the other side. This is the facet joint. Can you see the joint? And there's some phleum here which I have to take it out.
Mahisha, try increasing the irrigation pressure. It may clear your vision.
No, there is some haziness in the scope itself from beginning. Yeah. No, there was some haziness. It is not fully clear, but it's okay. We can manage. Okay, can you see the opposite root there? It's clear now. थोड़ा ग्रास पर just a little bit phleum we have to clear, then we are done.
Ease of surgery and predictive.
So Mahesha, how do you decide adequacy of decompression, especially on opposite side? How much lateral you would like to go?
Yeah, you have
lateral
to fully decompress the root on the opposite side. You can see here now, dissector, the opposite root is completely free now. So at least 2-3 millimeter space you have to have.
And those
See the
small
opposite
bits of
side.
ligamentum phloem, would you try to take that out as well, or you just leave it behind?
This we can take it out, but it doesn't matter. This part, it's not going to give cause compression. Kerison?
Fine.
Unless there is something in the foramen.
Yeah.
interaction change.
Interaction. तो जता रहेगा.
But if required, we can even decompress the exiting route on the opposite side. Not a problem. So we just have to remove some more bone here on the cranial side, on the other side, then you can see the.
So that's just for demonstrative purpose, right?
Yeah,
You
yeah,
won't
yeah.
need to.
This case it is not required. So here we have decompressed both the roots, dissector, ipsilateral and contralateral, and the dura. So this is the ipsilateral root here, which is free. I can show you now. There's something wrong with the vision actually. Kerison?
Yes, sir. We can see it. It's a bit hazy, but we can appreciate the complete central cord as well as the both side roots.
Yeah. Give me a dissector. Dissector. Yeah.
Yes.
Okay, so this is the root. Can you see? This is lateral root. This is the disc here.
Yeah.
Root is completely decompressed. We have enough space there. Kerison? Both
Very
side
nice.
roots we have decompressed. हाँ वो करेंगे. So no problem. So we will finish the other level also.
Okay.
So this decompression is finished, bilateral.
Fantastic.
And also you see the facet. So the pars is here, the facet is
Yeah,
here.
pars is
Okay.
preserved,
She has a very
compressed.
narrow canal, but we have preserved enough for facet.
Yeah.
Okay.
Very well done.
Yeah. Okay.
So anyone any questions?
Dilator. So you can continue with the talks, dilator, and we will finish one more level.
Hello.
Yes.
I
please,
think
हाँ.
Rakesh sir, just we can proceed for the lunch, and we will not telecast. We will just run in the background. We will not talk about this level. And anyone who wants to have a lunch and want to see the 2-3 level decompression can sit inside the conference room and can see. Okay. You proceed with the lunch. Okay.
Yeah. Okay. Thank you.
At 2:30 or once this finish, we'll start with the cervical one. Posterior cervical laminectomy 2 level and foraminotomy. C5, C6 on the left side, 6, 7 on the right side. We have already posted in the group. You can see the MRI in the group also. Thank you.
Okay, Bhupesh bhai, we are going with lunch.
Yeah.
You can continue.
Yes.
Yeah.
Yes.
Okay.
Thank you. Thank you.
ठीक है हाँ ठीक है हाँ गिव मी द कॉटरी अभी मोनोपोलर उसको फुट प्लेट लगा दिया फुट प्लेट लगा दिया पेशेंट प्लेट है हाँ ठीक है हम मोनोपोलर ट्राई करेंगे ये पानी ऑन कर दो वो थोड़ा 60 कर दो और स्प्रे मोड और 60 भूपेश भाई
हाँ
काम कर रहा है
ना
हाँ
ये कितने पे है
अभी 45 है मुझे
अच्छा काम कर रहे हैं पर पता नहीं
ज़्यादा करना पड़ेगा 60 करना पड़ेगा
65 कर दे रहे
60 और स्प्रे मोड में
आपको सेमी यूज किया क्या चेंज किया इंजीनियर नहीं चेंज किया ना
Chuk.
So we will be starting relive surgery session. Everybody can join. Please take a seat. So we are starting relive surgery session. Please take seat.
Hall.
Hello. Hello. So we are starting with real life surgery cases. Everybody, please take seats. We are starting with posterior cervical laminoforaminotomy by UB, demonstrated by Dr. Saisau Sa. Over to you.
So, how many of you are? Good afternoon. I am Dr. Shaishav Shah. I'm a spine surgeon in Vadodara. So, how many of you are already into spine endoscopy? I mean, who are already doing endoscopy? So, basically, the question I wanted to ask is how quickly one can go from lumbar to cervical. Are you already doing cervical cases? So there is an article wherein it suggests after how many cases you can do you can jump from simple decompressive surgery lumbar to endo T-lift, thoracic and cervical. So first is lumbar stenosis or a disc herniation that we start with. Then after around 30 cases, you can go from decompression to a fusion surgery. In a fusion surgery, then gradually the curve increases and you are able to finish it off much better, adequately, and in time. Once you achieved that, which generally takes around 60 to cases at least, or a cervical laminoforaminotomy, and then finally cervical multi-level laminectomy. So that is how you gradually go from a decompression surgery to a T-lift. Check. Hello. Cervical multi-level laminectomy. चालू है how okay yeah So I'll be talking on cervical laminoforaminotomy and discectomy. She's a 40-year-old female having, sorry, 40-year-old female having left-sided upper radiculopathy, tingling numbness on the left upper limb, left triceps weakness, and hypoesthesia on C7 dermatome. Arm pain is more than the neck pain. And this is the MRI. As you can rightly see, there's a disc fragment on the left side, C6, C7. Patient is not having any symptoms on the right side. I've put this, but the patient is asymptomatic on the right side. So we planned for a left biportal endoscopic cervical laminoforaminotomy and discectomy. So positioning is important because we want, this is a discectomy. Sorry again. So we need to flex the neck, reverse Trendelenburg position, and that will increase the interlaminar space, which will help us to remove the disc adequately without removing more bone. Because this is a cervical laminoforaminotomy. In doing a foraminotomy, we need to remove some part of the SAP facet as well. Initially, we started as an ipsilateral cervical laminoforaminotomy. Then there were articles saying that inclinatory cervical laminoforaminotomy is good. So we started standing on the opposite side so that we can go underneath and into the foramen more. Now, if it is just a decompression or a foraminotomy, we do that. But if I want to do a discectomy as well, I go from the ipsilateral side only, because removing underneath the root is much easier when I go from lateral to medial. I generally mark with my needles and I dock at the V point, delineating here in the AP view and confirming the level in the lateral view. Sometimes visualization of the C6, C7 disc space is difficult. The space, the major difference from a lumbar surgery is the portals have to be wide apart because the depth is more in cervical spine. And the marking in books generally say that it is at the pedicles, but the distance between two pedicles is very less in cervical spine. So generally your incisions are much wider apart than what we generally do. Radiological marking is not possible. We generally see it on the skin. At least 1 inch has to be there, rather more than 1 inch. I mark it with the needle, and in that direction only I put my stab knife, and the stab knife goes directly, and one knife, the upper knife, I try and hit the bone as well, because that gives me a faster this thing. I can reach the position. Soft tissue dissection is much more faster when I do that. Then this is the scraping of the bone that we do. This is a blunt dissector that is being used. The cranial obturator is, I dock on the bone, and then my dissector hits this metal first, and that actually guides me to the bone. So that is how I reach the bone, because triangulation is the main thing in biportal endoscopy. And when I know that this is on my bone, I am quite safe when this directs me to the because it is a blind thing, and then I start scraping. Medially, I scrape it quite a bit because soft tissue dissection is quite faster when I scrape more. As I always say, scraping more for 20 seconds saves you almost 10-20 minutes inside. I use these cannulas. You can see I use these cannulas to secure my portals, just as we do in shoulder surgery. Once we've done that, once the portals are secured, after some time, when I start burring, I actually remove that this cannula when I'm doing burring work. So this is the first view inside that we get. In cervical spine, generally what happens is there is good lot of soft tissue, much more than what it is there in the lumbar spine. And we are more cautious in cervical spine initially. So scraping is all the more helpful there. These cannulas also help me to retract the soft tissues. The sets have metal cannulas also. Speedy के भी तो बताया नहीं हमारा. Yes. Okay. Go fast. Yeah. So this is I scrape with the RF cautery. You can see the bone. Generally, the principle is the same. We try and find the V point, but the V point sometimes is not that greatly visible because the overlying lamina and the facet joint is like this. So we generally see left to drill down some part of the cranial lamina and the facet joint. I generally use a diamond drill here because more finer work is required. This is the lower lamina, and that is the cranial one. The cranial one is at a height than the lower. So the setting first is outside. This is 120, 120, or as they said, 4, 4 or 6, 6, whichever is comfortable. And then once you're inside and near the dura, you should use it at 2, 2. RF, sorry, RF setting, the one which I am using. This is my tech. This is my tech. Sorry, Depew. I've been using this since the beginning, so I'm comfortable using this. There are a lot many companies now that are available. Absolutely. This is actually, I mean, this is definitely not plasma. Plasma is more, the firing is more, but the dissipation is lesser than the RF. But this is more soft. You can say this is more soft. I keep this slow, but my work can be slow than the plasma. Plasma is, the dissipation is less and you can concentrately work more faster. The second advantage is RF में थोड़ा charring होता है, but plasma will not cause charring of the soft tissue. So once I've drilled the cranial part, I'll be able to see the V point much more better. But it is more soft. I mean, this is the soft but the dissipation, theoretically, the dissipation in plasma is lesser than RF. It is more, firing is more. I'm very happy using Depew RF. I've not changed because I already have that before that. Okay. Okay. I think you're the best person then which one is better because you use both the things. Yeah, because I've seen plasma. I've operated here and a few other places. So they have plasma. In plasma, in lumbar spine, झटका ज़्यादा मारता है. झटका ज़्यादा मारता है. Actually, nothing happens. Yes, absolutely, nothing happens. Nothing happens. So the goal is drilling step. We generally divide this into 3 steps. 3-step drilling: cranial drilling until we see the edge of the flavum, lateral drilling of the facet joint till we see the edge of the flavum here as well, and the caudal drilling, if at all required, some part of the pedicle can be drilled. So that is 3-step drilling from cranial to caudal. And once we've done that, just a hook can actually help release the flavum from the neural structure. And there is always one layer between the flavum and the neural structure, which is very easily tackled by the RF, much better with the hook RF, I'd say. Hook RF can actually lift the layer and coagulate. If we've not coagulated that, it actually bleeds a lot and it definitely lengthens your operative time. So I'm generally drilling this more gives you more axilla. Drilling lower lamina and the facet SAP is actually more helpful, so that the disc could be at the axilla of the root, and drilling this more will definitely land you up directly on the disc. So always aim drilling more on the lower aspect, lower lamina and SAP. I've not seen the upper edge of the phleum yet. I'll do that later because I'm aiming more for the axilla. I think after doing cervical multi-level laminectomies, the cervical laminophoraminotomy is now much more refined. We are doing much more refined cervical laminophoraminotomies once I've done cervical laminectomies. I think previously I was more apprehensive near the neural structures and everything, and now I think I've done more of laminectomies. I think I'm more this thing near the root. I know how much to drill, what to do, because we opened up everything with the drill. I think now I generally prefer more of endoscopic laminectomies only. 3 levels we do. Yes. And we had to do 4 level, but and this is a diamond drill. This is Bharat BH. No, I think no, this is Striker one. This is Striker. No, Striker's Sumex. Striker Sumex. I think coarse diamond પણ આવે છે આમાં. I think this is fine diamond. Coarse diamond would be much more faster. I think on that day I might not be having the coarse one.
Diamond can kill.
This is better. And this is safer. But that is faster. So that, I mean, there is a pro and there is a con to both the things. Safety first for me. And just as, I mean, myelopathy. It was a cervical myelopathy case. Multi-level stenosis. Yeah, I think you were asking me the time for that. I think the first level takes me like around 40 minutes, but the second levels are much faster. Almost in 2 hours, we were able to do 3 level laminectomy. We were able to do only from only those 2 portals. We were able to do everything, all 3. Myelopathy patient. This is laminophoraminotomy. Cervical laminectomy. We were discussing about. We do endoscopic now. Laminectomy, 3 level. We are here to do a 4 level laminectomy. We've done 3, but I think 4 can be done. We need to have 1 more incision in that, I think. Both. So it is a tip sparing surgery. So what happens is I drill some part of the ipsilateral part, and then I go contralateral first. I do the contralateral drilling first. Because what will happen is there will be cord fallback that we are expecting. Once I've done 1 or 2 levels, we expect a cord fallback, and then the contralateral would be difficult. In lumbar, actually, you can push and go there onto the contralateral side. It is not possible in cervical spine. So it is contralateral that is to be done first. We drill the whole spinous process, so the tip gets floating. And then we actually go on you can actually go to the contralateral side. You can actually do bone stripping, lamina stripping with the RF on the contralateral side as well. I use always in the neuro monitoring. Initially, we actually had a few things like just the drilling part. If you've done just the drilling part, the neurology improves. I mean, on IONM, the MEP improves. That even the monophasic becomes polyphasic, as well as the amplitude increases. But after flavectomy also, it increases a lot. So sometimes what happens is there were articles, I was reading articles that the flavectomy might not be required. So in initial cases, we did that actually. But in subsequent cases, when we did a flavectomy also, the MEP improved much more better. So flavectomy is always required. I don't get misguided with few articles. I got in my initial cases, I did not do that flavectomy in all cervical levels, but flavectomy is equally important. And there are two main things: no punch technique, release the flavum, and block flavectomy. That is actually required in cervical and thoracic cases. No punch. Even in dorsal also. So we've grown. I mean, initially I used to do that, but we've seen that there were signal changes in MEP. Luckily, we didn't have the complication. So we now we are saying it has to be no punch technique. Drill. You can use, but you have to be careful there. Curettes and dissectors as well as curettes also, but you have to be careful there. I mean. Foraminectomy, if you know the steps, you need to know the anatomy. I think that is not much of a hassle there. As I said, the layer between the phloem and the neural tissue is the most vascular layer, and then if that bleeds, we need to tackle that. But preemptively, if we do that with the hook RF, I think that is not much of an issue. Yes. Endoscopy. If that is what I'm saying. If I stop this irrigation, you will be able to see good amount of bleeding coming there. But the fluid is actually helping with me with the bleeding aspect. Now I'm targeting for the cranial edge. Might not be necessary sometimes, but it is to complete the adequate procedure. Okay. Inferior aspect. Not done anything, huh? Directly into the axilla. Yeah. You will see here, I actually lift from the inferior aspect only. Yeah. When we actually did end block flavectomy in cervical spine, we were actually surprised. It was so small. We were thinking like we might have missed it, some part. So even after doing this, you can see the axilla is still to be opened somewhat. You can delineate the route, I think, here. Yeah.
start using a fixed protocol.
Much more safer. और नहीं देखा है. So I've been asked to keep it raw. बाकी I edit करी दी दुआत. So initially, these cases, cervical disc herniations, I mean, I think we generally say in our textbooks that these cases are generally conserved. So I've seen both the patients conservative as well as discectomy. I think my operated patients are much more happier than my conserved patients. No, I mean these discs definitely improve with conservative management. Controversial thing.
Controversial statement. So
I'm saying my
so-
personal experience.
No, I understand. But cervical disc herniation, on day one, patient will come with severe pain. But at times, if you conserve, majority of them settle down in 2 to 3 weeks. Only thing is, at least they should be reasonable enough to cross that time. Many times I have seen huge disc on follow-up, no pain. So majority of cervical can be conserved. Cervical disc with a motor deficit, like a deltoid weakness, C5 palsy, is very common. At times, hand weakness is very common. And those patients who have failed those trial of conservative, then definitely surgery. But yes, patient will be happy. Means day one coming in with a disc, you operate, next day they are happy. Conservative would take time. That's at the same time. But yeah.
No, but I mean, what I was coming to the point is, once in the conservative management, there is post sequelae that is somewhat going on. Trapezitis, cervical vertigo, and these things actually settle down after a long time. The pain, the arm pain is settled, but the trapezitis and the cervical vertigo goes on for a long time.
Yeah, true, but then you should not be advocate. It means
okay.
At times, any surgery is surgery, right? There are some complications as a surgeon. We don't accept, or we do feel that but it's ultimately a cervical spine surgery once in a while.
Yes.
Very few cases now safety has improved, but still there are some cases where we should have some complications.
So that is a
fragment.
Fragment is out. As we talk, that fragment is done.
We will meet some senior surgeons. Like when I was doing residency, my boss, Dr. Dev Pujari, neurosurgeon, he would do any extent to conserve those cervical radiculopathy. So cervical radiculopathy was not to be operated. That was the kind of dictum. Yes. From there, we have switched to a place where there's definite role in failed conservative or motor deficit.
I think more of endoscopic surgery has a role. Is it so? Because more of endoscopy that is actually making us more confident.
Definitely endoscopy, but before that also, like so I have graduated from open posterior cervical laminoforaminotomy
from the tube
to tubular to endo.
Endoscope.
Endo is definitely superior, but even open posterior cervical foraminotomy, just recently one patient that came for almost like 13 years follow-up for another case, and then she said that cervical. So even open cervical laminoforaminotomy is not that invasive and would give excellent results, but endoscopy is definitely superior. But it's how the things have evolved over last 2 or 3 decades. as the number of surgeons increases,
I think it is about, I mean, see,
safety as well, and better diagnostics, more diagnostics, more experience, more precision. And microscopes have got better, MRI got better, endoscope got better.
so I think there are a lot
Huge
many
work.
fractures which were conserved previously are now operated to get a better outcome. I mean, conservatives definitely better.
And at the same time, people's tolerance as well. Like initially, people were ready to lie down for 3 weeks or so. Today's patients are not ready to wait. Their pain
Patience-
tolerance is not that much.
Patients, they don't have patience.
Yeah. That is another reason.
I think that's it from cervical MF.
Thank you.
Thank you. Thank you.
Thank you, Dr. Saiso. It was a wonderful presentation and we had very good discussion.
Any questions?
Any question from the audience for Dr. Saiso?
No, I think we did that with the cautery preemptively. नीचे जो वो जो डिफरेंशिएट हो गया था वो पार्ट नीचे दिख रहा है. With the cautery we actually वो प्लेयम को लिफ्ट ही cautery से किया. वो the membrane actually went away. Hook RF was not used. Yes, but the hook RF definitely helps when you are not able to go in straight away.
I'll go in next.
Yeah.
So for UV, is it difficult to go for the shoulder side of it?
No, sir. I think if we drill some more part of cranial, we can definitely go to the shoulder. We want to see the total, yes. Yes. Feeling part is more than one.
Thank you. Thank you, Dr. Saiso. Now we will have another relive case. So meanwhile, any questions any delegates have regarding any surgery we have seen from the morning?
Yes. Yes. Patient was relieved with the in that case. Patient was relieved with a good part of pain, but patient had some residual pain. Because I had already opened up the foramen. The patient was relieved with the pain, but patient said that some pain is left. So I can differentiate that those patients in which I have removed all the fragments, those patients are much more happier. But that patient was eventually happy because we also know that conservative management also helps.
So one patient, initially I thought on table that patient had on pre-op MRI, I thought it's a soft disc herniation. On table found that it is very hard disc herniation. So I ended up doing just a foraminoplasty. Then patient did well eventually. One patient had operated, one of physiotherapists really was just standing behind me. Surgery went very well. There was nothing, but patient developed post-operatively upper limb monoparesis. Eventually, patient recovers at 6 weeks, but again, pressure pump, I thought that was the issue rather than anything else. Because surgery we finished in around, I guess, 20 minutes. It was quick in, quick out. But patient developed pain relieved, but worsening of pain. Yes, hook, but not handling too much. I had a looked at video again. So when I use hook, I retract the root cranially, not go to medially.
So now next relive surgery by Dr. Rohit Delat, para UB. Yeah, over to you.
Good evening. I am Dr. Rohit Derat. I am from Surat and I will be presenting para UBE. So directly going to the case, this is a case of 71-year-old male complaining of right side severe leg pain, who was already operated for laminectomy 3 years back, but symptoms were still there. If you can see, there is huge disc osteophyte complex here. So there were multiple options like relief and micro disc by will say, but what we chose was para yoga, and you can see very nice decompression of root, and this is the bony work. This is one more case, high level disc L23, which we could remove. This is third case, high up migrated disc 3-4. You can see traversing and exiting part very nicely. So this is far out syndrome, again root decompression. So extraforaminal disc, up migrated disc, and far out syndrome. These are the basic indications of para yogi. Bertolone, sir. Same one isthmus lateral to facet. And yeah. So when there is a disc which is central, paracentral, we do normal UB. But if the disc is in foraminal or extraforaminal, para UB is better. So the anatomy is different. We have to look for exiting root. We have to preserve radicular artery, and here the ligament of interest is foraminal ligaments. And this is the working area: isthmus, transverse process, and SAP. So I'm presenting a case of 68-year-old female with right side severe radicular pain. She's significantly diabetic. SB1 was 10.5, and this case was done 2 days back. This is different patient. Yeah, okay. This is facet. This is transverse process, mammillary process. So this is isthmus here. Here is transverse process. This is cranial side. Since I'm doing on right side, I'm standing on right side. Clearance of soft tissue. Again, this is raw video. Just speed is 2x. There is significant osteophyte at the facet joint. Identifying mammillary process. This is mammillary process. Sorry. Okay. Sir?
Where do you doc start?
Isthmus. I started on isthmus. This is mammillary process going towards transverse process base from where we insert the screw. Working on transverse process. This is separating the muscular attachment to the mammillary process. This is again facet joint with osteophytes.
Initially, the posters were
targeting on isthmus. Now they are.
But now we start.
Initially, they were targeting on isthmus. Now they are targeting on facet or lower pedicle. It is like that.
So there are, I think, 2 ways to do it.
2 ways to do it. Yeah.
That's fine. Huh?
That's
I think talking on isthmus is much more faster and easier.
Yeah, I do like that. So this is again isthmus.
So docking on isthmus, you
This is
identify exiting
transverse
root
process, mammillary process,
and then come down. Or you dock on the facet, go lateral end. So both philosophies are acceptable. Both approaches are acceptable.
So this is routing fluted acromion burr. I'm burring the mammillary process. You can see the cancellous part of mammillary process and inferior margin of transverse process. I'm burring the osteophyte of facet joint to improve my vision.
Yeah. So when I was doing MIS, I used to go land up inferiorly, go to the lateral of the facet and go to the isthmus. But exiting root has a constant relationship. So when I do endo now, go to the isthmus TP junction, find out exiting route, and then
Then yeah,
follow exiting route and come below.
I think isthmus is safer and better.
Unsafe.
Yeah, some coding people say isthmus is unsafe. That's why.
So
Because
more unsafe because
they feel that dilator might slip from isthmus and hit the root.
yeah,
They
so
think
at times
probably.
whenever there is large disc and significant compression, your root is just beneath the
Beneath the,
so
yeah.
at times when you put a punch, you may take a bite of that root. So that's why they may say it is unsafe. But anatomically it is safer.
Yeah.
If you are below, then there is no risk to exiting root.
But there is always a phlegm that is there.
A phlegm. It is same as in interliminal there is phlegm. Here also there is phlegm which will protect your root. So like in interlaminar space, we search for separation of ligamentum phlegm cranially. Here we search for separation of ligamentum phlegm below the isthmus.
What is the advantage over transfemoral endoscopy by doing a para?
No. So
No,
one
see.
thing is your scope stays away from the root.
Away from the root. In transfemoral
So
endoscopy,
transfemoral, your-
sheath goes inside
your
the
scope
disc
is-
space. It literally crushes the root if there is a significant.
So
hit disc.
post-operative paresthesia is
Chances
less.
are very less. Yeah.
Visibility is better, and your decompression is more complete.
And
If you are doing an outside in technique,
just like
Yes,
It is
yeah.
just like
so
this.
that's what I'm saying. If we are doing a transfemoral endoscopy,
if you do an outside in technique, I think it is just like this. But I think we are more comfortable and it feels more better.
okay.
Here actually you can decompress the upper part of the foramen.
foramen.
This is the root of the root. By transfemoral approach, you can never go to the root of the root.
You can go to the shoulder.
But if we are targeting just a fragment, if we need to remove just a fragment, then I think the transfemoral endoscopy is better compared to this.
So all the root is hunt the pathology
Under pathology, yeah.
and then select that.
Yes.
If you want to tackle the migrated tip of the superior articular process, which is impinging the exiting root, then it's a transfemoral approach.
If you see here, ligamentum phlegm is slightly getting separated from here, and exactly here is pedicle and root. We expect like this. So I'm taking CM here to check where I'm just below the root or near to pedicle. There was pedicle here. So clearing soft tissue to make more and more room, more and more space there. So again, I was looking at CM here, where my till where I have cut the facet. While burying the superior edge of facet, we should never go below the upper margin of the disc. That will destabilize the facet joint. Sir, while burying superior articular process tip, Like we should, how much to burr? Like we should see in CM, we should not go beyond the upper margin of the disc. And after doing major work by fluted burr, I'm using diamond burr to do final work to separate the ligamentum flavum. And if you see, there is almost ligamentum flavum getting separated from isthmus and lower part of processus. Yeah, and there is root here. Once should identify, you can walk on the root and take out the ligamentum flavum. This is common bleeder site here, but just because it is endoscopy, we can see it and we can coagulate it. It is very difficult to do this, control this bleeding with tube or any Wilsey approach or open approach. This is vessel, yeah, artery. So there is root here. This is 30 degrees also. The Panipati you.
In this surgery, you get a few case.
Yeah. So we have to take care of this artery. This is artery, radicular artery. It bleeds. Whenever you see it, coagulate.
How often you get DRG irritation symptoms?
Very less, honestly speaking, very less. No, not much. Not much. While doing this step, my RF setting is always on 1. This is ganglion only.
I think you can also delineate that foraminal ligaments.
This is disc below. This is loose fragment. We can appreciate very easily. So I'm using pulsatile RF. 1 second, 1 second, 1 second, and not continuous RF. That was disc. fragment is out and decompression is done.
You showed a case of high level, high lumbar paracentral disc.
Yes, sir.
During para-IVF. In that case, how did you go?
Till I could see the lateral margin of thicker set. Yeah, I'm not able to see. But in higher lumbar level, it is very easily, appreciable, or it comes naturally.
Going here, it doesn't like खाली लोग पास तो वाला tension, पैसे तो वो tension.
Yes. So there is a decompression. पैसे तो टेंशन है तो किस तरह से टेंशन છે અને
What I'm saying is,
yes sir,
4 or 5 fires for paracentral
પેરાસેન્ટ્રલ નહીં પણ એમાં સર ઇન્ટરલેમનર રૂબીઝ સારું છે ને તો પછી જરૂર તો નથી, જરૂર નથી. સો આઈ થોટ ઓફ યુ સેડ ઓફ હાયર લેવલ ને સર. ઇનફેક્ટ 1 2 2 3 માં પેરાસેન્ટ્રલ ડિસ્ક હોય તો આ બેટર છે રાધર દેન ગોઈંગ ઇન્ટરલેમિનર. લાઈક આજે હું 1 2 2 3 માં ઇન્ટરલેમિનર ગયો તો પેરાસેન્ટ્રલ મોટી ડિસ્ક હોય તો રાધર બી વધારે સેફ રહેશે. Same para will be same thing. You have to, yes, sir. You have to burr slightly isthmus, some facet, and after identifying transverse, you have to burr the transverse process inferior margin till laterally.
So more burning was sweet.
Yes, sir.
Also, for a significant
Final soft tissue clearance. ગ્રેવિટી આ બ્લીડિંગ બંધ કરીને જતો તો કેટલું બ્લીડિંગ આવે છે, થોડું બ્લીડિંગ હતું એટલે પાછું આરએફ કર્યું છે. ઓકે આ બુક ઘણા વખતથી દબાઈ દે છે. થેન્ક યુ.
About the indication.
Yeah.
Various indications.
Sure, sure, sir.
Let's say that virtually or just go where the support.
So this was the pathology here. Transverse process touching here.
What?
Transverse process touching the ala of the sacrum. Yeah.
And in MRI, you need to see coronal image.
Yeah.
You need to ask the 3D cut to the radiologist. And the
Rakesh sir.
view.
Rakesh sir.
Cut.
Tomorrow case, I burred significant of isthmus and this process to see the upper side. 3 4 ऊपर સુધી છે ત્યાં સુધી હતું.
Right now, we there's an article on that. You ask them to do a recycle protocol for that. Yes, but should be like recycling. And very difficult to directly yes, sir. Is that you need to have this support at the angle of L5. But the surgery before.
Yes, sir. Sir, first I drilled isthmus, transverse process, and superior facet joint. I knew there was osteophyte anterior to the disc and posterior to the disc, so I was not worried about instability there. So I drilled more and more of facet joint, and transverse forces to make the space. We identified the route. Yes, sir. Sir, I'm coming, sir. I identified the route after removing the ligamentum flavum and went in the axial of the root or below the root. And from there, I could remove with scoop and disc forceps and dura gradually small amounts. It is disc osteophyte complex, but it will never be like that of natural bone. Even though disc osteophyte, we can scrape it out.
Then you don't have to put any screws or anything.
Sir, as I said, patient was having something like always disc syndrome. Everything was ossified. Anteriorly, disc was ossified. There was disc ossified complex. Patient was having absolutely leg pain. There was no back pain.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Rohit, for a wonderful presentation. Now, Dr. Rakesh sir will show about thoracic decompression, endoscopic thoracic decompression. Over to you, sir.
If any complication of fluid collection. These are the known complications.
Hello. Yeah.
I'm so confident. The clip, yeah.
Okay.
That's why I said this up.
Okay. Just wanted to show you, this is monoportal posterior cervical endoscopic discectomy. Just one edited video just to this is preparation, identification of V point. So that's the V point, superior lamina, inferior lamina, facet joint. And then you start drilling superior lamina. Very minimal requirement of superior lamina. You work more on the inferior lamina to go to the axilla. And medial third of facet can be taken out. So that's working on an inferior lamina. And that's a facet joint. Medial third of facet joint can be taken out. Maximal is half, U and half can be taken out. This is punch. You can use 1.5 or 2 millimeter punch. So now you can see that there is a flimsy layer over this nerve root. At times you may not need to tackle it, but at times that is very thick and then you need to take it off. So now I'm just going inferior to the root and take the disc out. But there is a thin layer over it. You have to put a blunt hook or a RF beneath it and coagulate at times. Yeah, that. But I think pediculotomy will give you inferior extension. If your disc is getting underneath the root, they don't help you much. That instrument is going flat only. It's uh-huh.
Yes, very nicely described how to go, without manipulating the root patterning. Yes, 50% prediction.
Pedicle electronics. Okay. Okay. So this is monoportal endoscopic posterior thoracic decompression. So from a learning curve endoscopy wise, I think first thing would be L5 S1 disc herniation. Second, gradually moving to a higher level disc herniation. Then ipsilateral lateral stenosis, then lumbar canal stenosis, then adding cervical foraminotomy, far lateral disc, and then would reach to a dorsal. So it is later in your learning curve because it is a high risk surgery. Myelopathy worsening, paraplegia are a definite risk and should be done under neuromonitoring. So this was a 68-year-old lady with a bilateral leg pain of 6 months, was unable to stand or walk more than 10 minutes. But recently, for over last 1 week, patient had a bilateral lower limb weakness. And basically, patient had a L3-4 stenosis, 4-5 stenosis, and recent myelopathy because of the STAN 11 severe cord compression signal change. And you can see axial level 10 11 significant stenosis with hypertrophied ligamentum flavum, and L2 3 and 3 4. So all three severe stenosis. So under GA position is prone, and this is how you dock. Again, docking at the spinolamellar junction, and you can see that was the thickened ligamentum flavum. So you dock at the level of spinolamellar junction 10 11, and then you get in. So that is rostral, that is caudal, medial, and 6 o'clock is lateral. So identification of a spinolaminar junction, that's a spinous process, that's a lamina. So at dorsal, it's basically a spinous process splitting kind of technique where you drill the base of the spinous process, go on the opposite side so that the tip of spinous process remains floating, and then you go on opposite side. So you have to prepare. It's basically a lot of drilling required. So once you get adequate expertise into drilling, then only you should jump into this thoracic cases. And a lot of soft tissue preparation is also required because it's a quite a long segment bony drill. So then I'm starting drilling at the level of spinolaminar junction and going superiorly. And the base of the spinous process. So making a trough and gradually widening the trough, that's how we drill in a thoracic spine. So basically I'm going from base of the spinous process, spinolaminar junction to rostral and reach above the level of the pathology and then gradually come down and go on opposite side then. Thoracic disc mount. Thoracic disc, I use basically transfacetal ultrasound guided approach, but not endoscopy. So those who are expert into transforaminal, yes, thoracic becomes easier. Yeah. So nowadays, I think indication for transforaminal is predominantly thoracic disc or upper lumbar disc. So here a lot of drilling required at the base of the spinous process and then go on the opposite side, the lamina. So I'm coming more medial, drilling medial aspect of the ipsilateral, you can say ipsilateral part of the spinous process. Angling the scope and going on the opposite side. So I'm trying to go on opposite side through the spinous process, basically. Base of the spinous process. Cervical, yeah. Cervical and dorsal would have similar techniques, I would guess. I have not done cervical, I have jumped to dorsal first. So next step is cervical. Basic advantage of doing dorsal endoscopy is what I've realized that myelopathy recovery is much beyond expectations, much beyond traditional, very fast. And yeah, compared to open, that is very surprising. I was not expecting that to happen, but I've seen patients recovering faster. Say again. Bone scalpel, I'm not a big fan of bone scalpel. So, it's what is safer in your hands. I think, to me, in my hands, I have found burr is safer than bone scalpel. Bone scalpel doesn't work whenever there is ossified yellow ligament or an anteriorly OPRL. So whenever there is aberrant ossification, I think drill is more safer than bone scalpel. Not in endoscopy. It is talking about general. Yeah. Could be okay. Monoportal, we don't have bone scalpel. Yes. Yeah, true. So that's what I was saying, that advantages of OLF with endoscopy is better visualization, getting a good plane and good post-operative recovery. So I totally agree.
The separation from the dura is also very good
Yes.
endoscopy.
True.
In that, it is far superior.
True. So those traditional things are a challenge with endoscopy now. So in cervical, yes, one above, one below was the norm because you depend more on a falling back of cord. But with endoscopy doing focal as well, you are getting a recovery. Even in in my traditional training, my professor used to say it's cervical lamb is always 3 to 6, but now it's no longer true. Means yes, there may be some space required to fall back the cord, so you go little bit above, but maybe one level, half level is fine, not full. So we have done good number of focal lamina.
मुझे okay.
So gradually I'm going deeper. You can see inner cortex is there. So going superior, ipsilateral, and then contralateral as well. I use Ingber whenever there is bleeding or I'm near the cord, I use diamond. But even open
I want
microscopy or
to
MI,
start with the 5-6 first.
diamond.
क्योंकि
In endoscopy for bleeding purpose, I use diamond burr more rather than a safety, I guess. So you can see that ligamentum flavum is coming now. So you take out outer part of the ligamentum flavum and then again drill. So layer by layer drilling is being done. So here also part of outer layer of ligament is calcified, so that is also being drilled.
Do you use the neuromonitoring in this case?
Yes, always.
All the dorsal cases.
All dorsal. And I prefer to do all myelopathy under neuromonitoring, be it whatever procedure I am doing.
Okay.
You are safer in court of law as well and clinically as well.
Okay.
Even a single case can ruin your reputation, and in a court of law you can be challenged now. Unless neuromonitoring is at times not available, then probably I may not, but otherwise I like to use.
So now you're burring lateral to the on the contralateral side.
So this is ipsilateral side again.
Okay.
Yeah. So that is going contralateral side. Yes. In a dorsal case, you. Because you don't want to sleep, right? You don't want to put efforts. It's a effortless drilling is what is needed. So 50% of surgeon is, I think, tools. Or however good surgeon without good tool cannot perform well. So very thick ligamentum fluum. I'm burring at the same time. Whatever ligament is coming in between, I'm taking it out. Outer layers of ligamentum fluum. So you can see there are some areas which are like ossified ligamentum fluum. Yeah, that I'm trying to go underneath and find superior margin. So go above the level of compression, yeah. And then that's a midpoint. So going above the ligamentum fleum and is also safer as well. You can see again, this is a calcified component of the ligamentum fleum. So now I'm switching to diamond burr. So at times your drill can be helpful to take off that soft tissue element as well and burying that calcified component. You can start seeing the cord now. So that's a straight punch, tube sheath punch, 2 millimeter tube sheath punch. And that's a calcified ligamentum fleum. You can see it's calcified. Yeah. Yeah. So like last week I had a case where it was calcified ligamentum fleum which was arising on one side. The cord was pushed on another side. So I did open and realized that almost superior to inferior half and half portion of completely ossified. So initially I made an island, but still it was causing significant compression. Then I had to take out it completely. So there was long arachnoid layer and I had to use a Duragen, multi-layers Duragen and a T-seal glue to reconstruct the dura. So those cases are really challenging. Yeah, so you always get CT scan done in this kind of cases. So to see one calcified ligament is how badly calcified, how much you need to drill. And at times you can make out dural calcification as well. You will see that it's called tram track sign. You will see 2 layers of calcification with a hypodensities in between. That would give you an indication that yes, dura may be calcified. So we are now you can see the cord pulsations well. That's the inferior aspect, and then going on sides and going inferiorly. You can see the lateral margin of the cord now. So I haven't learned no punch technique. I'm using a lot of punch. That may be next stage. So you can see inferior lamina, SAP, and then there was a facet joint. Yes, yes, gravity. Gravity and keeping it at low setting and closing few. Because you don't want any complication due to gravitational or irrigation basically. So going slow, keeping irrigation slow and using punches, smaller sizes punches. I can fast forward this, I guess. Huh? 10 minutes? Okay. Okay. So that's the opposite side lateral to the cord. So now we are almost near complete decompression. Just contralateral inferior is remaining to a certain extent. So that contralateral SCP part and the ligament. So decompression is almost over, just a hemostasis and then. So showing all margins, inferior, superior, ipsilateral and contralateral. You can see cord pulsating well, clearing out of soft tissue. So that's a post-operative The patient also had a 2, 3, 3, 4 stenosis. So I did that through MIS, and you can see post-operatively, that's MRI, you can see excellent decompression. That's a CT scan showing bone, that's a facets even stable and well decompressed. 2, 3, 3, 4 also well decompressed. And clinically also patient made a remarkable post-op recovery. Yeah, thank you.
It's a wonderful case, Dr. Rakesh
Yeah,
sir.
thank you.
Any question from the audience? Any question? Yeah.
So you can ask any question, not only related to this case, but any confusion, any question regarding endoscopy, where do we start, anything that bothers you.
In this case, especially if we are having midline dural entanglement in OLF or the dura is ossified, where do we end the bone work?
So whenever you feel that on table the dura is calcified, try to make an island. You separate on all around so that the calcified component stay floating. So you can use blunt hook, try to separate it from all around and drill it out. And then if that calcified component remains floating and you feel that the cord is decompressed, that you can leave it behind. The last case I did last week, I was explaining to that we did an island technique and still that dura was significantly compressed and the cord was not bouncing back. So in that case, you have to sacrifice that calcified dura and use a dural substitute. So we did that in a whole length and then cord started pulsating well. There was some CSF leak and predominant place there where arachnoid was intact. And then you have to reconstruct the dura. You should use dural substitutes like Duragen, G patch, and you can use over which TCL glue you can use.
Even for multi-level cases, we'll do the same. Like adjacent levels, we are having dural calcification. Like
Yeah, you can do the same thing. Same thing for cervical as well. Cervical calcified ligamentum flavum or dorsal. The same principle is drill out all around, make an island, try to take out completely. If not, just make an island. And even if after keeping an island, if there is compression, then you sacrifice the dura and use dural reconstruction. So you drill it till you make it paper thin. So it's called eggshell technique. You just leave behind thin rim and then you can use blunt hook and take it out. So that's why you need a new burr, you need a diamond burr. So you just like a paintbrush, you keep on thinning layers and then you sacrifice at one point. So in this kind of cases should be done under neuromonitoring only. So then you know when you are safe and you know when it is not.
Any further questions? So now we have live surgery, cervical double level laminectomy. And after that, we will have a live surgery, 3-level Calip endofusion. So it is now starting. Meanwhile, if you have any question, anyone have anything, you can ask.
Hello.
Yes, Bhupesh bhai.
हाँ Rohit bhai, we are audible, na? So we are ready with the next case.
Okay. So can you give us an idea about the case?
Yes. Patient is having the right side. Hello. Yes. Patient is having.
Audible.
Patient is having a right side weakness, right upper limb weakness, especially extension of the elbow is very weak, and patient is having a right side lower limb reflex little bit of exaggerated, and patient he has a history of some sudden jerk in the neck and followed by weakness. So on MRI we see there is there is a cord myelopathy in the right side, very large disc herniation in the foraminal area, and C5, C6, C6, C7 cord myelopathy and right side disc herniation, and C5, C6 there is a foraminal stenosis on the left side.
Yes.
So our plan is to do
MRI. Please focus on MRI.
Yeah, just focus on MRI, sir. So our plan is to do laminectomy at C6-7 level. So C6 laminectomy and removal of the disc on the right foraminal area. And we'll do the left side foraminotomy only. And just to decompress the left side, traversing C6 now route. Okay?
Okay. So starting from which side?
We are starting from the right side. Okay.
Right side at?
Right side C6, C7 we are starting first.
Okay, 6, 7 right side you are starting.
So what I thought was we will do the right side at decompression at 6, 7. Then we go to the
Okay.
left side, then C5, C6 discectomy and remove the C7 lamina from left side.
Yeah.
Okay. This is the plan.
Okay.
Laminectomy the right. You go on the left side, you have to be very, very careful.
Because
You may go and hit the cord. And it is easier to remove from the left side than
Yeah.
the other half.
Yeah.
So not a problem.
Yes.
So that is the
Plan.
Okay.
So scope is a IQ scope. Yes.
to come. You can focus on this last CM, the and so we have marked the C6, C7 and C5, C6 the lateral
Pani.
So especially in the lower
Just
level,
being
mic on kar do. नहीं hello, yeah, you can hear me. क्या हुआ?
Hello.
Hello.
Rohit bhai.
Hello. Hope everybody is awake.
Yeah, we are all here.
Okay. So
Okay.
sometimes you cannot get a true lateral in cervical spine, especially the lower levels. Then we have to rely only on AP view. Especially if you have a C7 D1 pathology or something like that. And some patients with short neck, even C6, C7 may be very difficult to localize in the lateral view. So can we have the dilator cannula, brother? लेंथ चाहिए मुझे, वो थोड़ा हटाओ इससे. हाँ ठीक है. Okay. So dilator cannula. So we have just made 2 incisions, one on the right and one on the left side. So we will height upper. We will just insert the dilator cannula. So we have tilted the C-arm so that we get a true picture. Dilator. So this is a 8 millimeter dilator and 9.4 mm cannula. So we have to check. Should. So it looks to be in the correct space. We'll take a lateral and confirm again. Lateral. Are you seeing image or Bhupesh stomach? Lateral please. ये थोड़ा हट सकता है. ठीक है. हाँ ठीक है, छोड़. Dilator.
Dr. Mahesa?
Yeah.
Can you?
Yeah, we are just checking the C-arm. Should.
So are you planning to remove en block lamina?
Height upper. What?
En block laminectomy?
No, we are not doing. Should. Okay. No, it's not clear. Okay, can you?
2, 3, 4, 5, 6, 7.
Okay. So we are at the correct level. The lamina is bit up only. Okay, shoot once. Okay. C-arm out. So we are at the correct level. We are not doing en bloc because pathology is a little different here because there is pathology on both sides. So we are not doing en bloc here. See, I'm out. See, I'm out, please. Okay. Table fully down.
We were curious to see the end block.
Yeah, but this we don't have a case for en bloc, so.
Yeah, just a note. Just
Yeah.
joking.
Table fully down, please. नहीं ये नीचे जा नहीं जा रहा है क्यों? हाँ irrigation on please. कॉटरी दे दो नहीं कॉटरी RF. So grass. So the plan is to land on the V point. V point start drilling. So we are doing ipsilateral decompression of 6-7 here, and then go to the C5 C6 on the other side, and remove the C7 lamina from the other side. This is the plan. Okay. Can we have the RF? Okay. ये थोड़ा लेंथ चाहिए मुझे. ठीक है. ओके. ऑन फुट स्विच किधर है?
Which scope you are using?
This is a 5.7 mm working channel. So नहीं काम नहीं. एक मिनट. So this is the best scope you can have because it is very convenient. 5.7 working channel is good enough for almost any pathology.
So are you standing on a support for the height or it's
No,
fine?
no, I'm not standing on any support.
What is the length of the scope?
It is 12.5 centimeters.
Okay.
We get 10 centimeter scope also, but that may be short for some patients. Yeah.
What is your preference? The like Revo scope which is very long,
No,
that is more better, shorter one?
No, shorter is always better. Now Revo have also changed their scope to shorter
Yes.
scope because if you continue to work with the Revo scope, you will get rotator cuff tear at 60 years. 100%.
Yes. Very true.
Hold this. Give me the curate. So first task is to find the lamina. You have a cutter? Give me the cutter.
Can you orient us?
Yeah, I am standing on the right side of the patient. So 3 o'clock is cranial, 9 o'clock is caudal, and 6 o'clock is lateral, and 12 is medial. So curate, cutter, okay. Yeah. Wonderful.
Yellow lagi, mana भी lagi.
accurate. So that looks like the lamina. Okay, this is the C6 lamina. Can you make out?
Yes, yes.
So we have to find out the lower lamina. I mean C5 lamina. I mean C6 lamina. This is the C6.
Lamina, yes.
Yeah. We are on
C7
C6. C7 will be below.
RF is better for here?
No, this RF is. I am used to monopolar because that will cut in the tip. This does not cut at the tip. Cuts only at the. Otherwise, अच्छा है. So. हाँ, correct. Because I am used to monopolar. Okay, this coagulation is good. So in cervical, it is better to confirm once you do the soft tissue work, unlike lumbar. If you have doubt, it's better to confirm. 1 centimeter, you may be in the wrong place, grasper. शायद चाहिए कटर 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 कॉटरी अरे थोड़ा लेंथ चाहिए. So it is important to identify the joint also, joint and the lateral edge of the facet, so that you are sure how much bone is there. See, this is a joint you can make out.
Yes, we can appreciate it.
Yeah, this is a joint. This is the V point somewhere here. Accurate.
So will you expose
ठीक है, अभी नहीं चाहिए.
till the lateral of facet joint, just a part of facet joint?
I generally expose the full length of the joint.
Okay.
So that I know how much of the joint is remaining. Grasper.
Okay.
Cutter. Platform we foot instruments they cannot work. So grasper.
चालू कर दे.
Cautery. So we are just clearing the soft tissues on the ipsilateral side. So this is a C7 lamina. C6 lamina is here.
Okay.
Okay, this
So
is
you
full,
will
full C6.
clear
Yeah.
on the ipsilateral side only.
Yeah,
But when you are planning for en bloc laminectomy, then how much clearance you will do?
When I'm doing en bloc, I have to go to the opposite side completely. Here.
Okay.
So here I will remove this. I mean, this patient does not have too much of a stenosis.
Yes, yes.
It is mainly the flavum and some disc.
Okay.
Not a extremely narrow canal. So this is whole thing is the C6 lamina.
Yes.
Okay. So if it is a severe stenosis, I will take off the entire C6. But here I don't think I have to remove the whole lamina. I will keep some of the lamina intact. But we will just confirm the level once.
Mahesha,
Yeah.
if you have to do complete laminectomy, you expose opposite side by going above the spinous process, or you drill
No,
at
under
the
the
basic?
under the spinous process. Under the
Okay.
spinous. We don't go above the spinous process.
Okay, okay.
We undercut the spinous process and then go to the opposite side.
Like floating spinous process technique, just like that.
Yeah.
Okay.
So this is the extent of the facet here. So this is the whole of C6 lamina. We'll just confirm that we are at the correct level and then start drilling. Because in the cervical spine, one maybe half centimeter mismatch will be in the wrong level. And a little bit of change in angulation will be at wrong level. So I'll just confirm one AP only, just tilt this way. I need 2 AP. No, other way. Yeah. Okay. Okay. Come inside. Shoot. So it's a true AP. You see, I'm exactly at C6, C7 space. Out. So I'm good. Okay. Out. So give me the burr. So now we start burring till we see the flavum edge. ये नहीं चलेगा. हाँ, long burr चाहिए. So we have to see the edge of the flavum at both sides, cranial and striker का है तो दे दीजिए. So ये फुट स्विच आपके पास है, प्रेस कर दो. Yeah. So this is the diamond burr. Normally we use cutting burr only, but diamond is okay in the cervical spine because lamina is not very thick here. So press. So you can even use a diamond burr.
Okay. And you will start burring from V point or?
No, here I am pressing. If I am doing only discectomy, I will start at V point.
Okay.
But here we are doing the decompression also, so don't have to start at the V point.
Okay, so both the lamina
Spinolaminar,
till the margin of the ligament of flavum.
spinolaminar junction and go laterally.
Okay.
This is working all right, no problem. For cervical, even a diamond bar will do. Stop. So it's almost the end of the press. Stop. 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 So you see that's the end of the flavor. See? Okay. Press.
Yes.
Okay, press. Press, brother. So if you want to see the opposite side, I will show here only.
So,
Okay.
don't you control the drill by yourself, Mahesha, or you
Stop.
ask someone to control the drill?
Huh? Now the control is with the brother. I don't have control. Press. 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 Press.
That is a risky, man.
No, no, I have the depth, no? So depth is in my control. Brother is not controlling the depth. So stop.
We don't know when to stop.
So this is beyond the midline. So now the control has come back to me. So let us see. It's not working. नहीं स्ट्राइकर लगा दो नहीं फुट स्विच है रेडी थोड़ा कटर दे दो हाँ So sometimes this midline muscle and fascia you have to cut to go to the opposite side. Striker नहीं हो रहा है. Okay. So that is the spinous process. Can you see? Okay. Most important thing is you should never press on the cord. Burr. Grasper. 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 That is the most important thing. You should have good control over the scope, cannula and instruments, everything. Burr. Okay, 1 minute. So, press. Stop. Press. Press. Stop. Cutter. Cutter. कटर चाहिए पानी खत्म हो गया चालू है कॉटरी लेंथ चाहिए थोड़ा प्रेस पास है किधर है ओके ओके ठीक है बर हाँ प्रेस मी है ओके so finally I have the burr under my control.
So you are going now below the base of spinous process?
Yeah, to the opposite side.
Okay.
Till you reach the lateral margin of ligament of flavor? How would you decide?
Yeah. Have to see the other end. RF. आपके पास टिप RF है? ये नहीं टिप चाहिए. Hello? Can you hear me?
Yes, yes.
Okay, okay. I thought it is off. Okay.
No,
Tip RF. In the corners, it is better to use normal RF, not this powerful one. So this is mainly the phlegm which is causing compression. So once we take out the phlegm, give me the burr, I'll burr this side. Or lower side it can start.
Okay, so now you will work on a C7 laminar.
Yeah, yeah. पानी आ रहा है ना? Okay. Sorry. Yeah. साइड शुरू हो रहा है ट्रांसकेमिंग
ले रहे हैं
ओके इसमें ज़्यादा ड्रिलिंग नहीं चाहिए क्योंकि अटैचमेंट इज वेरी नियर.
So in the lower lamina, you don't need to remove much bone.
Yeah, little bit you have to remove, but not too much. You see, already I have reached the attachment of the phlegm. So what happens when we go under this? Sometimes there will be bleed of tissues because muscle is exposed to the drill. So RF मुझे चाहिए. RF tip चाहिए. I don't want to use the powerful RF here. Cutter. Cutter. So any questions? So most important thing is the control of your instruments and the cannula and the scope. Should never press on the cord. So I'm just cutting some soft tissues over the spinous process here so that vision becomes clear.
So to make a space to work on the opposite side.
No, I already worked this tissue, just block your vision. So that's why I'm taking it out. Polar.
So you prefer to coagulate or cut?
If it is not bleeding, you can cut. Yes, very good. Excellent. So these are muscular bleeders which we need to coagulate. ठीक है, अच्छा है. This is RF from Bharat Biotech. Yes. Okay. See, the anatomy is very clear. We have drilled the base of the spinous process. We have gone to the opposite side. Burr again.
Yes.
Burr. We have not exposed the cord. The phlegm is still intact. Okay, there is a attachment that side. RF. Press.
So what is the biggest challenge you find in cervical, Mahesha?
Cervical, you need to have a lot of patience because sometimes drilling will seem endless. So you have to have, and also you cannot press on the cord. That is dangerous.
Right.
Burr. So now I am using the spinous process for resting, so that I am not pressing on the cord. Already you see other side, it is already released. Okay, give me accurate. So you can see the fat on the other side. So you have a smaller curate. हाँ नहीं कटर दे दे एक बार कटर but again I have to do little bit of release here cranially.
So you use bar for all the procedure, or you will use the punch?
I use burr mainly.
Okay.
Kerrison punch I will not use here.
Okay.
Because putting a kerrison is dangerous. And also
so it's like
we
no
are,
punch technique.
and also we are not doing any monitoring, so the better save them.
Okay.
So you can see the attachment getting released slowly. Okay, give me the curate. So this is a very, very thick phlegm. आपके पास स्मॉल क्यूरेट है छोटी सी so better to use smaller and smaller instruments here so that you're not going to cause any compression.
Okay, so you will use the curate only for
Yeah,
separation.
yeah, and also see where I'm putting the curate, it is the place where there is no compression. I'm not putting curate where there is compression. So these are small things but very, very important. If you put a big kerrison, patient will have neurologic deficit.
Yes.
So this is okay. You see there is enough fat also there. So this is released here, and lower down again we have released.
Okay. And what was the size of the burr which you used right now?
I think it is 4 mm.
4 mm. Okay.
Yeah. You see, you can see the other side. Okay.
Yes.
Give me the kerrison now. So here there is space. I can put a kerrison. Okay.
Okay.
Because compression is under the phlegm, not under the bony edge.
Yes.
Okay. So I have space now. I will go with the kerrison to the opposite side. To release that.
So you are releasing it from the other side.
Yes.
And what are
You can see the
what will you-
root there, other side. So that means I have reached the other side.
Yes.
Okay, you can
So
see
what do you
that.
do to counter the epidural bleeding?
There is no bleeding now.
If it happens, what?
See, there is nothing. You see the opposite cord very easily, both sides. Now I come to this side. So what I did is I have kept some bone in the ipsilateral side, so that when I go to the opposite side, I am not pressing on the cord. Got it?
Yes.
Okay.
Hmm.
Now I will complete the work on this side.
Ipsilateral side. Yes.
Okay, give me the burr. So this is the V point.
This is the viewpoint facet. Yes.
Yeah.
Very well appreciated.
So now we come here with the burr. सलाइन है ना? ठीक है, नहीं आ रहा है इधर. हाँ ठीक है, ओके, ठीक है, ठीक है. Yeah.
Tea coffee is ready. You can take it and come back here.
See, lower down there is a very little bone being drilled, maybe 2-3 millimeters only. Okay, so this is the facet. So still I have 10 millimeters, so I can come till here. Okay.
Okay. So how much facet you will like to burr?
Maybe about 3 to 4 millimeters.
Okay.
So we have to see the edge of the dura, accurate, and the root. Let us see where the dura is. So looks like the dura is here only. You see, dural edge is here. Can you see? Dural edge is here. So that means I already drilled about 3 millimeters now. Still I can drill some more. Because there is enough bone here. Because there is a disc also to be removed. RF. So there is, when you see a bleeder, just coagulate it. That's it. Okay. Press. Okay. So when there is a bleeder, just coagulate. So that's how you control it. But so I have still a lot of bone here. So let us see.
I like to expose the shoulder and axilla both. Hello.
Yes, Bhuvesai.
So I usually expose the shoulder and axilla both and just confirm the decompression adequately from upper root and axilla and shoulder. So I think need to drill from upper lamina also, and also find the lateral edge of dura on the upper lamina.
Okay.
So that will complete your flavum resection on the ipsilateral side.
So this already, you see, the attachment of the flavum is finished.
Yes,
there.
yes.
So unlike lumbar spine, in the cervical spine there is no flavum protection to the root. So you cannot drill down too much in the foramen. It will cause root sleeve injury.
So the lateral edge flavum just stop.
So you have to use kerrison.
Completely exposed. So sometimes you may abrade the nerve root.
Okay, give me kerrison now. Can you see the entire length of the flavum now?
Yes, yes, we can appreciate it.
Now I use the kerosene. Okay.
So you will remove it and block.
Yes.
Very nice.
थोड़ा बड़ा बड़ा वाला है.
एक सुधी मस्त કર્યું સર.
grasper.
Here you may encounter the bleeding.
This may be from the bone. स्ट्रेट है, स्ट्रेट चाहिए. ठीक है अभी कैरिसन. So give me a RF. There is a bleeder. हाँ वो प्रेस्ड है. प्रेस. ठीक है. एक मिनट एक मिनट एक मिनट एक मिनट एक मिनट एक मिनट. प्रेस प्रेस. ठीक है. ओके. Kerosene small. So you can see the lateral edge of the dura. Of course there is enough bone here, so I don't think we have to go more lateral there. Clean. अभी स्कोप का विजन अच्छा है. So here you have to use kerosene. There is no other option. Okay, that is the root. Can you see the root?
Yes, yes.
Yes, we can appreciate it.
Yeah.
Very well.
Grasper.
Yes, yes. આખી લેમિનેર એકવાર આખી કરો ને ગાડી તો ઈઝી.
Kerosene. You can see the inflamed root here.
Yes, it is very inflamed.
Give me RF once. And it is pushed posteriorly. Press. ठीक. एक मिनट. Okay. Curate. Kerosene once. Kerosene. RF. Press. Okay. Curate. So the whole phloem is in front of you. We'll just release.
Yes, it is separated from all the sides.
Yeah. So other side we have to check. Okay.
Yes.
What is that sound? Any problem? Okay. Kerosene small. There is small attachment there. Can you see?
Yes,
Superiorly
yes.
on the other
On
side. So
cranial side.
just have to clear that. So once I clear it, it should come out. Cure it again. So looks like it is released. So we take it out. Okay. Grasper. Grasper. Grasper straight. It is stuck here, you see. Highly adherent.
Yes, adherent with dura.
Yeah. Because of the compression, it is adherent there. Okay, give me the grasper. Let us see if it comes now. Bada wala, short. Take this. So I grasped it and I am taking it out. Okay.
Yes, very excellent.
So whole thing came out. So this
Yes.
is the butterfly of cervical. Can you focus here?
Mm. Wonderful. Beautifully
Okay.
done.
Cervical butterfly.
Yes. Yes, we can appreciate it.
Okay. Take. So just rotations, you can go inside easily. So already it is inside. Okay. You can see the whole cervical cord there, except a little bit phloem posteriorly it's on the other side. Kerosene. Rest everything is out. Okay.
Yes. So that's just a part on the
Yeah,
opposite side.
that little bit I think it got attached there. You can see the cord pulsations very.
Yes, it is visible.
It's a little traces. पानी आ रहा है ना?
आप छोड़ दे वही बिजली लेवल से
थोड़ा आ रहा है दे दो. Press. ठीक है कैरिसन RF press okay कैरिसन again no I have just removed the phlegm and block stop so n block phlegm is removed see whole cord is here little bit it is little bit oozing there that's it. थोड़ा phlegm आपके पास 90 डिग्री है 90 डिग्री के RF नहीं we have reached the other side can see the edge of the dura there okay ये अच्छा दिखेगा डोंट वरी
मैंने 4 लेवल इलेक्ट्रॉनिक किया था अच्छा हुआ पर एक कॉर्नर में थोड़ा एंड ब्लॉक पूरा टोटल इलेक्ट्रॉनिक
सर्वाइकल एक ही में हो जाएगा नहीं है तो 2 करेंगे
डेफिसिट होने के चांसेस बहुत बढ़ जाते हैं
ग्रेजुएशन करें
बिकॉज़ ऑफ वाटर प्रेशर वी डोंट
इलेक्ट्रॉनिक्स पीसी इलेक्ट्रॉनिक्स एंड कंप्यूटर
RF
University of Pune Zarbanashak we were using it.
you can see the opposite side very clearly
Yes, it's visible.
okay this is the bone press yeah Garrison it's very clear now
Yes, yes.
that is the edge of the dura आपके पास छोटी सी क्यूरेट है एक बार छोटा सा क्यूरेट okay that is the route going there under this carry some small costume. Huh. There is a small bit of facetal bone. Let's try to take it out with the osteotome.
In the foramen.
एक minute. Hit.
Yes.
Right pen. Hit. Slowly. Kerosene. Small.
So it's like inclinatory foramenotomy.
Yes.
Okay.
छोटी सी ग्रास पर है. Okay. Okay, I think that is good enough. The opposite side is fully decompressed. Okay. We'll come to this side now. Give me a dissector.
Okay. So we'll do dissectomy on the same side.
Yeah. So we finished the decompression part. So this is the root here.
Yes, root is very well visible.
Shoulder here, but it is.
Yes.
I cannot retract it. So tip RF. There is something here. You see?
Yes, yes, in the axilla.
Axilla. RF.
Okay.
Press.
Yeah, fine. Next, Kelly fund. Okay, fine.
Okay. Dissector. Disc. So you see the disc is here. Can you see?
Yes, we are seeing it.
Whatever we saw on the MRI.
Yeah.
The disc is here.
So it's a big disc. Yeah. So you are in the axilla.
Yeah, it is in the axilla. Okay. Disc है इधर. हाँ इधर ही है ना. Okay, grasper. हाँ बड़ा disc है. I cannot even retract the root. Okay, grasper. नहीं अभी नहीं चाहिए. एक बार मार्क करना पड़ेगा. Then I can take it.
Yeah, fantastic. That's very nice. That's a huge disc there.
Accurate. Yeah, it's a big disc actually. It is pushing the whole root up. As we said, it is in the axilla. The other disc probably is in the shoulder. Lower upper
I think
leg.
that also
Grasper, yeah, it's here only. Still there is angle है. Give that. नहीं give straight one. It is useful in many situations. Yeah. You see the whole thing came out with that. Yeah, RF. Press. Stop. Okay. है cranial है. Accurate. तो है. I want to retract the. Give me the root retractor. बड़ा वाला. हाँ. नहीं है इधर. ठीक है वो है अभी इसमें. हाँ.
के बाद
grasper small. Okay, hold. ये बड़ा हो गया. Okay. Okay, give me a dissector. Dissector. Once. So that fragment is out. Now the root is retractable. Maybe a small fragment is here. Root retract again. So this is the osteophyte. That's okay. We don't have to do anything. And here there is a small piece. Root retractor. Give me grasper. Grasper. Brother, grasper. छोटी सी grasper. Small grasper.
मैं सर्वाइकल में छोटा स्कोप यूज करता हूँ, ग्लास फॉर्मेल वाला, और ये रिट्रैक्टर मेरे लिए बहुत परफेक्ट हो जाता है.
नहीं वो नॉर्मल नहीं वो रिट्रैक्टर भी चलता है.
बड़े स्कोप में चलता है, पर मैं छोटा स्कोप यूज करता हूँ ना.
ग्रास्पर. ग्रास्पर नहीं ये सॉफ्ट है. सॉफ्ट है. उप्स ये बहुत बड़ा है. दैट इज द प्रॉब्लम. क्लीन नहीं अभी वो शोल्डर में रिट्रैक्शन नहीं हो रहा था उसके लिए नीचे से आया. Problem is these instruments are too long. Need to have the. ठीक है. ठीक है. Give me retractor again. Root retractor. This is the transferable rotor sleeve, so that's why it is too long. Grasper angled and straight is it? Straight grasper. Grasper. छोटी सी. Whatever goes. So now you see I can retract the root very well. So there is no problem. Take एक और give the retractor. Give me the other one. So take. Give me the dissector. So I think we have removed almost all the herniated fragments. We'll check in the shoulder of the root. Okay. Now we can see it is easily retractable, unlike in the beginning it was not retractable. Now we can see it's retractable. There is no problem. There is no disc here. And one small fragment is here. We take it out. Grasper, angled one. Angle curved, yeah. Root retractor. So any questions? Are you happy?
We are fantastic.
ग्रास्पर स्ट्रेट इसमें चलता है.
Yes, Mahesha, well done.
Okay. है तो दे दीजिए. Grasper.
Mahisha, you are using a round cannula or a beveled cannula?
It's a beveled cannula.
Okay.
This is not ideal for this. आ गया ठीक है. So this is the regular rotary tractor I am using. ये थोड़ा tight है. So this is the normal rotary tractor for this. Okay, give me the grasper. हाँ. I think all the disc is out actually. ज़्यादा नहीं है इसमें. Can you appreciate the disc space? So there is nothing more to be done. Give me RF. I'll just do RF and then come out. Press. Stop. Can you see the disc space? Disc space, the root sector.
Yes, very clear.
The root is easily retractable now. Okay, this is the movement you should require. Okay, root is freely mobile. There is no more disc there. Okay, dura is free. Opposite side is free. Okay?
Wonderful.
Yeah. So I think if the other OT is ready, you can go to the other OT. Otherwise, I will have to shift to the other side now because for C5, C6, I have to shift everything to the left side. So that I will do now. Okay. So we will have to shift to the now. So we will take one Siam shot and then shift to the other side. Give me एक Siam चाहिए अभी. Give me a knife. ठीक है. Give me knife, brother. Knife. Take. So here you have to be a little bit careful because you don't want to hit the cord. Cannula. Cannula. एक मिनट. ठीक है. ओके शूट. थोड़ा टिल्ट कर दीजिए. यस. हाँ. गिव मी द लॉन्ग इंस्ट्रूमेंट. लॉन्ग इंस्ट्रूमेंट. एक मिनट. ग्रास पर चाहिए. एक मिनट. हाँ शूट. थोड़ा आप नीचे आइए.
Looks like 6-7.
Shoot. नहीं. He is above. Okay. It is 5-6 only. Okay. 5-6. Sure. Okay. Out. Siam out. Okay. Siam can go that side and I will have to come that side. Brother, you can stand here. I will go that side. You can give me instrument from that side. Okay. Siam बाहर लेके जाओ. हाँ. अभी Siam नहीं चाहिए. वो ठीक है. अभी स्कोप दे दो. वो थोड़ा इस तरह हटाओ. पानी ऑन कर दो और गिव मी ग्रास पर. मुझे स्टेप दिया तो अच्छा रहेगा. So this is the opposite side. Okay, give me the RF. Oh no, big one. Yeah, give. हाँ, short. हाँ. Press. So are you with me or have you shifted to other theater?
No, we are very much with you.
Okay, stop.
So you prefer to use a transforaminal scope for your cervical cases or
No. This is stenoscope only.
5.7 stenoscope?
Yeah. Press.
But what do you prefer?
Press. Yes, this is we don't use transference only for 5S1 discectomy. Nothing else. Earlier I used to do even stenosis, discectomy, everything with the scope. But bigger scope you can use bigger instruments and you can do faster surgeries. So that's why. And also to teach youngsters, it is easier with the bigger scope. So that's why stenoscope is the workhorse now. Stop. Give me curate. Curate. So same steps we have to identify the C5 and C6 lamina, part of which is remaining now. So this is the C5 lamina. Anyway, even if there is no CM, I can still confirm the level by going caudally to see my old window on this side. RF pottery. So this is the C5 lamina. Press. Stop. So can you see C5 lamina? It's very clear now. Press. Press. So we have to identify the remains of C6 lamina here and the V point. Stop. Curate. So this is definitely C5 lamina, and we'll just remove this bone, I mean the soft tissue over the bone, then you can identify the lower lamina. Give me kerison. Kerison. Here we are not going to do any decompression as such, just a discectomy. There is no kerison. There is no compression here except the foraminal area. कटर एक बार. Yeah.
Continue and please confirm my interest. Should I be selected for the pressurized donor to join? हाँ, मुझसे बात नहीं उसके बाद. सर कहीं पे ज्वाइन कर गया.
Okay. RF. Press. This is. I just want to check the lower. नहीं है. एक मिनट, ये क्या है देखता हूँ. ये 6 है या C5 है, देखना पड़ेगा.
Usually, these types
Stop.
of RF bands
Stop.
do not pass through 5.7 mm scope.
This which company it is? Curate. So which are used? Cutter. Okay, curate once. So I have to confirm the level again, because in cervical even half centimeter can give you trouble. Carrison. RF. 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 Normal RF. Press. एक minute. Press. Press. Carry. Press. 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 Carrison. Carrison. RF. RF. Press. 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 Stop. Okay. Cord. Hello. Okay. So C7. So this is C5. So this is C6 lamina. Anyway, I will just confirm once with Siam, okay, before I start drilling. Okay, this is our lower
C6, C7.
Yeah, C6, C7 we have done. Press.
Yeah.
Okay. So that is C6, C7, whatever we have done. We'll just confirm.
Nice.
So this is the Siam AP.
It is also shown the extent of contralateral decompression. What
See,
we
we
can
have gone to the other side completely. Okay.
Yeah,
Siam leke
wonderful.
aao. We'll just confirm the level and then start drilling. नहीं थोड़ा ऊपर आना चाहिए. हाँ पकड़ो, ओके, हाँ थोड़ा आगे आगे, थोड़ा टिल्ट करना पड़ेगा, ओके, शूट, okay, so 7656, okay, so this confirms the level, out, CM out, CM out. Anyway, the final confirmation is getting the disc, okay, so give me the burr, so now CM can go out, RF paper, that's one bleeder somewhere. CM can go out, yeah. Give me the burr. हाँ CM निकालो, ओके, ठीक है, ठीक है, गो, या नो प्रॉब्लम. ये टेबल हेड एंड नीचे हो सकता है, हाँ कर सकते हैं, हेड नीचे करना है, हाँ टेबल हेड एंड नीचे, नहीं, कैन यू मेक द हेड एंड लो, ठीक है, ओके, फॉरगेट, आई डोंट वांट टू, नॉट स्टेबल रहता है, ठीक है, ओके, ओके, ये दिस बी पॉइंट, वो फुट स्विच इधर डालिए, फुट स्विच, कीप द फुट स्विच दिस साइड, हाँ ठीक है, थोड़ा okay, so I'm just drilling the B point here, only discectomy, so there is no decompression or anything, probably there is a soft fragment, give me diamond bar, so there is some bleeding, we will just use diamond bar, हाँ ठीक है, press, ठीक है, but Kerrison first, Kerrison small, this is 5-6 level, ये इधर से हम नीचे का भी देख सकते हैं, नीचे का डिकम्प्रेशन, ठीक, Take. 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 ये थोड़ा इस तरह रख सकते हैं. और थोड़ा बर. हाँ ठीक है बर. हाँ ठीक है. So now I am drilling the lower lamina. Okay, you can already see the dura there. Kerrison small. So here, I think because of the disc, there is hardly any space there to go in. Yeah, to the foramen. Take. There is a huge disc here. So let us see where it is. To remove some phlegm to see the dura very clearly. क्या? नहीं ये चलेगा. ठीक है. Okay. Leave. So that is the dural sac. So I expect the fragment to be in the axilla here. Sorry, in the shoulder here. RF control in your hand. 8 minutes. Press. 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 Okay, stop. This is the disc probably there. Kerrison. So it is going. See, foramen is extremely tight. I cannot even put my Kerrison there. Okay, give me a dissector. I can see the roots, so I will try to retract the root, see if I can get some fragments out so that it becomes free. A fight. Garrison small STUV में उससे बीच में छोटा सा है 1 mm का 1 mm का है ये थोड़ा बर्फ डायमंड दे दो डायमंड बर्फ नहीं है ठीक है ओके स्मॉल कैरिसन तो क्यूरेट है ना छोटी सा क्यूरेट ये भी अंदर नहीं ओके very tight so नहीं चल रहा है देख ये हाँ अभी हो रहा है इट इज़ वेरी टाइट सो आई एम मेड टू फाइंड द डिस्क वेयर इट इज
सर अभी खत्म आपका सिर्फ एक वो रिलाइव है ट्रांसफर में थोड़ा वो खत्म करना है सिर्फ
हाँ कर सकते हैं अभी गिव मी सम टाइम
इसके बाद
हाँ इधर ठीक है क्या हुआ? ओ हाँ ठीक है ये सी दिस इज द रूट एंड हाँ पूरा osteoid है here न न इधर इधर ऑस्टियोफाइट है ठीक है इसका अंदर see this is a बड़ा ऑस्टियोफाइट इधर because if I do something I think it will stretch the root a lot हाँ 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 एंड अभी अभी रूट मोबाइल है इसी ऊपर से मोबाइल है नीचे थोड़ा देखूंगा हाँ कुछ किया तो प्रॉब्लम रहेगा हाँ हाँ you see the this is going freely carry some small so I think we just decompress and come out because मेडिकल आ गया करेक्ट वो पेडिकल है
Will a small hooded diamond burr help there?
So there is a pedicle over there. So he already filled the pedicle. Because of pedicle, he is not able to go there.
Dissector?
I think. Kavi sir.
हाँ वो छोटा ट्रांसफोरामिनल का कटिंग बर रहता है उधर हुडेड
So this foramen is free, you see. My instrument is going fully.
Sir, actually, patient doesn't have a symptoms on the left side.
Small case.
Hello.
Hello.
Yeah.
So
Okay.
I think should not poke too much because of
Yeah, that's why we don't want something which is not there.
Which is not there, and we just create a new symptoms.
कुछ है तो थोड़ा पुराना
थोड़ा ड्रिल करना हो तो कर सकते हो
हाँ अभी अंदर गया
ओके
ठीक है so I think so some decompression has happened.
So after this surgery we will finish Dr. Basu's live case of UBE fusion. Kavi sir.
UB fusion. Bhupesh, I couldn't hear you properly.
Hello.
हाँ.
Now I'm audible. Hello. Hello.
You're audible now.
हाँ सर इसके बाद हम डॉक्टर आनंद बासु का रिलाइव केस देखेंगे यूबी फ्यूजन देन आफ्टर दैट वी डू द ट्रांसकेमिन फ्यूजन ऑन नेक्स्ट केस patient is we are just inducing the patient and one level we have a infusion but we'll just see the one level and two level we'll just finish after that we'll see the thoracic transforaminal endoscopy of Dr. Mahesha.
Okay.
I need to show that posterior foraminotomy but the case has already happened so I don't think so we need to show it.
Okay.
So इसमें थोड़ा ऑस्टियोपाइट है इधर हाँ सो अभी रूट फ्री है completely root is fully free you see okay completely free there so
ये वो एक निकालना तो ये वाला यहाँ तो थोड़ा ये निकाल दो हाँ बस वहाँ
ये इधर पेडिकल है कैरिसन so root is completely free now that
yes I think it's very completely free I think this might be the end point of the
yes okay that can be अभी थोड़ा वहाँ जाएगा
हाँ अभी
थोड़ा जगह बनाए ना वहाँ
हाँ now it is fully free you can freely so you see soft better just clean this Press. That is the route going down. So route is fully free now. So I think we stop here.
So excellent surgery.
Very nicely presented.
So now you proceed with the UV fusion, and after 15-20 minutes we come up with the transdermal fusion.
Okay.
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 Okay, this is our lower
We'll
level.
complete the
So
UV
then-
fusion relive.
Yeah.
Okay.
Thank you. Thank you. Thank
Very
you.
nice, Mahisha. Excellent
Okay,
presentation
thank
and wonderful surgery.
Thank you.
Congratulations.
ठीक है मैं नीचे जाऊँ ठीक है ओके हाँ थैंक यू हो गया
अभी ट्रांसकेमिन कर दिया
हाँ ओपन
You must be tired.
नो नो आई एम नॉट टायर्ड
Didn't
आई एम
you
नॉट
थका दिया?
नहीं अभी कुछ नहीं हुआ
मैं ड्राइवर को बोलता हूँ
हाँ ठीक है
नहीं गाड़ी मेरे पास आप जा रहे हो अभी रुक रहे हैं तो मैं ड्राइवर आपका ड्राइवर है यहाँ हाँ तो आप बोल दो उसको आप सर नीचे
हाँ
चेंज करके
ठीक है
निकालने बघा क्या છે આપણો ચલ क्या करो એટલે એ પતી ગયો દીપ पे માથાની પટ્ટી कर માથાની પટ્ટી ને લઈ
Hello. Yeah. So good afternoon. We are almost towards the end of the day. Everybody is like tired. Seen a lot of endoscopic videos, images. I'll try to be short. So it's not exactly a real life surgery. I have fast forwarded the video at times. But what I'm going to do is highlight the, essence of the surgery and try to impress upon you why we are trying to do something different. So So I went to Chennai as a part of a live surgery, workshop, and I was given this patient to operate, and this is the morbidity in this is it was Chennai UB course, and the organizer said, "Sir, you have to operate on this patient." And I went to the theater and saw this morbidly obese lady, almost 120 kilos weight, and kind of if you want to operate on this kind of a patient with morbid obesity with any other minimally invasive technique, you have to make a hole and you have to struggle while trying to get to the bone and do the bony decompression. But we could do the surgery with two tiny incisions, tiny 8mm incisions. These are actually stab incisions. So now I do my UB surgeries with two stab incisions. So the question is UV surgery only minimally invasive on the skin, or is it minimally invasive to the tissues also? Whether it is more minimally invasive than tube, because some of the tubular surgeons can do decompression with a 16mm incision, 18mm incision. So is the incision matters? Does the incision matter only, or is there anything inside which is more minimally invasive that we are doing in UB, and why are we trying to shift from an established system of tubular surgery to a more technically demanding surgery, which we have to learn, pass through the learning curve. Some of us are established surgeons already, they have done thousands of surgeries. They have to relearn a new technique and apply it in their practice. So that takes a lot of toll on your body, mind, and takes a toll on your practice as well. So why do we need to make this effort to learn something new? Is there any advantage of using UB for fusion, for decompression? Let us see in this lecture. So the basic concept of UV is basically what we do is we are operating in a space which is a potential space and which is called sound space. I'm trying to explain to you that this is the lamina and this is the multifidus muscle. So you see this multifidus muscle is not attached to the lamina. It lies loosely on the lamina, and the space between the multifidus and the lamina of the spine is filled with loose areolar tissue. You can see here, this is what the space between multifidus and lamina looks like. So this white structure is nothing but fibrofatty loose areolar tissue. So this space is called Son space. So the muscle is not attached to the bone. If you follow the multifidus muscle, you see that the muscle is attached to the spinous process. It lies loosely over the lamina, goes laterally, and gets attached to the TP superior articular process part. So the SAP lateral part, the multifidus is attached. It goes laterally like this. And what we are trying to do in UB surgery is we are trying to get underneath the multifidus. We are trying to go underneath the multifidus, work in the potential space between the bone lamina and the multifidus. We are trying to avoid even damage to the multifidus. So this is a multifidus preserving surgery, and that is how, even if it is even if I make a longer incision on the skin, this will be more minimally invasive than any other technique of minimally invasive spine surgery. So that is why, and multifidus is a very important stabilizer of spine. And even in UB TLIF, so if you go back to my first slide, I'm calling it as ULIF. I'll explain to you later why I'm calling it a ULIF. Even in UB fusion, we are basically preserving the integrity of the multifidus muscle. So that is why it is more minimally invasive. We are working in the sound space, and the principles of UB need to be respected while doing the surgery. So this is a lovely image by Ashwin, which again shows that we are lifting up the multifidus and working in this, and lifting up the multifidus by water, by fluid. And we are working in this space between the multifidus and the ligamentum flavum and the bone. And we are doing all our bony work, decompression work in that space, which is a potential space. Because if the fluid was not there, this multifidus would have been lying on the bone and the muscle. So the space would not have existed. So when you go in with a tube, you see that there is a muscle on the bone and the ligamentum flavum. And to reach to the bone and the ligamentum flavum, what we have to do, we have to cauterize the muscle with cautery and reach the bone. And that is the step where you damage the multifidus. So in UB, we are not doing that. We are working underneath the multifidus. We are trying to preserve the multifidus, and that is how it is less traumatic to the less collateral damage to the body, and that is how this is more minimally invasive than other techniques. So that is the advantage of UB, and this is the crux and basics of UB, that why we want to shift from some other technique to this technique. So I wanted to spend more time on this slide because this is what is the basics of UB. So all these things, these are known facts, but let us come to a standard case that we see everywhere. Yeah, please, sir. That monopodal surgeons will be able to tell you. I have not scrapped anything. Let me go through my lecture. So this is a standard. This is a standard case that every one of us encounter in our practice. Stenosis, degenerative stenosis with instability on flexion extension X-ray, and we all offer fusion surgery. It may be open, it may be tubular, because I still do a lot of tubular surgeries, because when I have 4 or 5 cases in a day, I cannot do 4 or 5 UV TLIF because it's time consuming. And tubular surgery is very fast in my hands. I can do it in 50 minutes. So, but still, it's a mix in my practice. I do tubular surgery as well as UV surgery. It's got good results, tubular surgery. It's fantastic results. I've done close to 600 of these now. But UV, we are all shifting to UV for reasons which we are going to discuss. So these are the kind of operating steps. So this is, before you walk in, you should make sure that the OT setup is good, and you mark the portals at the level of the pedicles we've been seeing throughout this morning.
So the working pedicle, the working portal, and you have got two portals. One is the working portal, another one is the viewing portal. So in working portal should be at the level of, you make the two pedicles your two portals. That is the standard, standard thing that you can follow. But if you're doing a fusion surgery, your working portal has to be closer to the disc space. You can make the upper border of the lower pedicle your working portal. Because why? Because if you because you want your working portal in line with the disc space, because you're going to use the working portal to put in the cage into the disc space. If your working portal is not in line with the disc space, if this is your disc space and your working portal is here, so your cage will go like this, and it will hit the lower end plate of the upper vertebra. So that you don't want. And all your interbody work, for all the instruments that go for your interbody preparation work, you also want them to go along the disc space. So that is why your working portal in a fusion surgery should be as close to the disc space or in line with the disc space as possible. So what I do is I make the working portal at the upper border of the pedicle of the lower vertebra in case of fusion. And I make it directly over the pedicle. I keep initially the incision small, but later on I have to, after I've done everything, before putting in the cage, I just make the incision longer. Now that you can ask, why do not I start with a longer incision in the beginning? The answer is, if I start with a longer incision in the beginning, I'll lose more fluid during the surgery. So that is why I can save fluid by making initially the incision smaller. And then when I need to put in the cage, because to put in the cage, you need a retractor system to your assistant to hold a retractor. And you again need to put in a cage, which is like at least it has got a footprint. So while just before putting in the cage, I make the incision longer. Before that, it is just a stab wound that I place. So let us progress with the surgery. So you see, I'm cutting the fascia in a horizontal manner first, and then turning the blade and cutting the fascia in a craniocaudal direction also. And with my this thing first dilator, I'm going to dock at the spinolaminar junction, and I just dilate the track up to the spinolaminar junction. I feel the spinolaminar junction and I take it out. And then again, through the viewing portal, you see I'm putting a transverse incision, I'm turning the blade and making the fascial incision T-shaped. Because, you need the... So this is another tip. The fascial incision, even if you make a horizontal skin incision, but you need to make the fascial incision T-shaped like this towards each other. Because your scope is going to go in the caudal direction, and your working instruments will need to go in the cranial direction. So to allow easy movement of the scope as well as the instruments in craniocaudal as well as mediolateral direction, your fascia has to be adequately incised. Only the fascia, not the muscle. So that is another step. And again, if you feel that you are struggling with the instruments, handling of the instruments, and you don't have established a good outflow of the fluid, just make the fascial incision a bit wider and bigger. You'll find that the water flow has become better. So this is a good tip for people who are starting. And then again so docking point is the spinolaminar junction. This is the spinolaminar junction. So docking point. So what does docking and triangulation means? So I am trying to reach the spinolaminar junction from my working as well as viewing portal. And you see that again through the working portal, what I've done is through the viewing portal, I've just reached the spinolaminar junction, marked it in C-arm, dilated the tract, come out. So in both the places, I have placed my instrument in the spinolaminar junction, dilated the tract, come out. And now what I'm going to do is I've put in the trocar with the sheath inside. And now I'm going to do the triangulation. Sorry. यहाँ पर क्या कहाँ पे? Where is the cursor? कर्सर कहाँ पे है यार? इसको आगे कैसे कर सकते हैं? इसको यहाँ पे लेके जाना है। छोड़ो एक सेकंड। हैंग हो गया क्या? ये क्या हुआ? रुको रुको, हाँ ठीक है। So now you have seen, I have put in the trocar, the sheath of the scope and the first dilator, and I have marked my triangulation point, which is at the spinolaminar junction. Now, before I put in my scope, I'm using orienting myself. I'm orienting myself, and this is the first time I'm putting in the scope inside the patient's body. And the first view that I get is of lamina. The first view that I get is of lamina. So what is happening in this step? If you see, what is happening in this step? If you see, I have taken the scope inside this. I have taken the scope inside the son space, and the multifidus here. What you are seeing is exactly the bone, and the multifidus is above me. So I'm working in the son space with the multifidus above me, and so I can see the bone actually. And multifidus, since multifidus is not attached to the bone, you need not detach it. Oh shit. So and now what I need to do is I have not used any RF as of now, and the first time so the use of RF here is just to shrink the loose areolar tissue inside the son space and delineate the margin of the lower lamina. And I don't need to burn any muscle with RF.
Lateral.
So what I'm trying to do with the RF is just kind of create the space for the drill to go in and start burying the lower margin of the lamina. So till now, as I was mentioning in the surgery today also, till now I'm working in a potential space. So this is not an actual space. This is a potential space. I have created the space by using fluid, by elevating the multifidus, and I'm working in the potential space. So triangulation in this part is a bit tricky. And the moment I start drilling, the moment I drill the bone, I convert a potential space to an actual space where there will be pooling of water, and this space will become like this, and triangulation will become easier. So triangulation inside a knee, inside a shoulder is easy because you have a space there. It is an actual cavity. So you can put in two instruments and see each other. But here there is no actual cavity. You are creating the cavity by elevating the multifidus. But the next steps are like once I've created this trough, once I've started drill the bone, then this trough is created, then triangulation becomes easier. So if I hand over this surgery to one of my residents or fellows, they can continue to do the surgery even if they have not got good triangulation skills, they can still continue the surgery. So in cadaveric course, you will see that once you have drilled a little bit of bone, then initially you were struggling with triangulation. Once you've started drilling a little bit of bone, your triangulation will become easier. And the next steps are like quite similar. As we see, we keep on kind of drilling the bone. We keep on using the RF to shrink the loose areolar tissue that come in between. These are quite quite standard. In TLIF, we try to use as less drill as possible. Use more Kerrison punches so that we can preserve the bone for fusion. And you have to. So this is a slide where here you can see that in tubular surgery you have to damage the multifidus. There is no other way than to reach the bone than to damage the multifidus, which is not there in UV surgery. So here it is more minimally invasive than tubular surgery.
मारो माइक ऑन करने आज सेव कर जाओ सन हाँ.
So these are the steps. I'll fast forwarded it because to kind of to make things faster. So basically you use drilling. You go to the base of the spinous process like this. You keep on shrinking, and here what you can see is with the RF I'm basically what I'm doing is
एकदम मस्त ने
perfect. सेव कर दे.
चलो गाइड है.
हाँ हाँ.
ब्लड ले लीजिए है ना.
चल शूट कर.
वाह वाह देवेंद्र सु बुद्धि वापरो तो मैं आज बताया एकदम क्यारेक એટલી બધી બુદ્ધિ વાપરી લો છો ને. ચલો પેલું કરો દે ને પંકજ જતો રે.
So here what this part is, this is basically the IAP, surgery articular process.
बताए.
I have with the RF I have removed the capsule. This is the part, this is the IAP, and I'm using a bone scalpel to cut the parts through the parts and remove the IAP.
Hammer.
Knife.
Sword.
Knife.
Sword.
So with the bone scalpel, I have removed the cut the IAP, and this is the SAP. This part is in the big. This is the SAP. I've removed the IAP, and now what I'm doing is I'm gradually doing the flavum resection. So I've using the standard tricks to remove the flavum, and once I've done that, this is the disc space. As you can see that I have reached the disc space.
चलो lateral साहब तुम्हारा lateral आवाज है के बाहर से.
So the thing is, once I have reached the disc space, I only need to cut as much SAP as possible as required, so that my cage can go in. I do not need to remove the entire SAP. If I remove the entire SAP, I will remove the
આપણે ઓલો ઇલેક્ટ્રેસ્ટ માંથી કાઢીને લખી એના જગ્યાએ માંથી કાઢી લીધો ભલે સારું. મેરો તો બધે મેરો જ છે.
That amount of SAP resection is required to put in the to do the interdistal work. And I start the I ask my assistant to medially retract the traversing route, and I start doing the interdistal work.
थोड़ी हाइट डाउन कर बताओ. ओके सो
चल क्यों नहीं रहा है.
चलो हैमर हैमर
नॉट वर्किंग.
વસંત ઓકે ચલ મને પાછો ગાઈડર આપી દે. પેલું કેન્યુલા આપી દે.
So you can use the RF to do the annulotomy, and I can see inside the disc space. I use blunt instruments to curate the end plates, the cartilaginous end plates, and to reach the spondral bone. And this end plate preparation is basically done under direct vision and under direct tactile feedback. So unlike MIS TLIF or unlike tubular TLIF or other forms of in open TLIF also, we do. You see, this is the vision from MIS TLIF, tubular TLIF. This is using Pentero microscope, which is quite a high-end microscope. Even with using Pentero, you see that I'm doing the end plate preparation blindly, not under direct vision. I'm using my tactile feedback to assess the adequacy of end plate preparation. And if in this surgery in MIS TLIF, if you go with an endoscope inside after doing the display preparation under microscope, you will see that lot of end plate, lot of cartilages end plate is still left behind, and you have not done the end plate preparation adequately as you would do in a UV surgery, where under direct vision you can, without damaging the bony end plate, you can remove the entire cartilaginous end plate and remove lot of disc material for the bone graft to go in, as well as a cage of big footprint to go in. You can even put in 2 cages. You can put in big footprint cage like an olive cage inside. So your disc space end plate preparation is very, very adequate in UV compared to. So this is, look at this view. Under direct vision, I've prepared the end plates, and I can see the ALL also. I can go to use a 30-degree scope to go inside and see as much as I can preparation I've done in the medial side. So a lot of end plate preparation under the vision that you can do using a UVs. And also you can see that I've decompressed the traversing as well as the exiting nerve route. So it is minimally invasive outside, but inside it is maximally invasive. This much amount of invasiveness is not possible with microsurgery, with open surgery even. So the skin incision may be small, but inside the work that you do is far extensive, I would say. And this is, we can put in under, you see that we can put in the cage under direct vision. So this is after doing the end plate preparation, I asked my assistant to retract the nerve root, and we can do the put in the cage. There's a peak cage I'm putting in under direct vision. In and compare this to tubular TLIF, where you have to bend the patient to the opposite side to do opposite-sided nerve root decompression. You have to bend your back like this sometimes, and putting in a cage also sometimes becomes under a small tube. Your vision is obscured, while putting in the cage. So and in UV TLIF you can do it at ease, and your overall your ergonomics of the surgeon is much better compared to microsurgery. So at the end of the surgery, you assess the adequacy of decompression. You see the cage placement. You can use the C-arm also to see the position of the cage. You have done a bilateral complete decompression of the traversing route, and you have done a 4 nerve root decompression. Actually, you can do it with UV if you while doing the TLIF, because you can while only doing decompression, you can decompress 3 nerve roots: ipsilateral traversing route and contralateral, both the traversing as well as exiting route. But if you knock off the IAP on the ipsilateral side, like while doing the TLIF, you can do a 4 nerve root decompression actually. So the extent of decompression that you can achieve is much bigger. And you can put in a cage. You can here you can see that I've put in almost a 14 size cage inside the interbody space. And if I have got a good hold, I sometimes get away with putting in only 2 screws. Not all cases. If I'm happy with the bone quality, if I get a good snugly fit cage, big size cage with good lordosis, I sometimes, just kind of put in 2 screws on that side, so the TLIF is done with 2 small holes. And in TLIF surgeries, I do put in a drain, because even if you are happy with the hemostasis initially, while putting in the screws, there's a lot of activity happens through the two portals that might cause muscle bleeding. So sometimes I do, again go in after putting in the screws to check with the scope if there is any epidural hematoma or not. But I feel safe to keep a drain after surgery for 24 hours. So this is not a standard. I'm not promoting this surgery, but sometimes I do get away with this. And checking hemostasis again is as explained by Dr. Della today also. I stop the water flow and check if there is active bleeding or not. If this is the screen, after stopping the water flow, I will not use a drain. But even after stopping the water flow, if I see blood coming from here, there, everywhere, I'll try to stop the bleeding with RF. But still, even with all efforts, sometimes the field is a bit oozy. If you find an oozy field after stopping the bleeding and making efforts to stop the bleeding with your RF, it's better to put in a drain, because epidural hematoma is not uncommon. And the most common symptom of epidural hematoma, what is that is what? That is severe back pain, which is out of proportion to what you would expect after a UB surgery. So if I do a ULBD, and the patient after 2 hours, I have lots of videos. After 2 hours, the patient is walking. I'm asking the patient, that your leg pain is gone. Yeah, the leg pain is gone. You feel any pain in the back? The patient is thinking, not much. It's fine. Not much pain. So this is the response of the patient 2 to 3 hours after surgery. If I do a ULBD, and but if the patient is, oh sir, it's too much pain in the back, I can't. But the patient does not have any neurology. That means the patient has developed a epidural hematoma. Neurology, if there is neurology, you need to go in and evacuate the hematoma. But if there is pain which is out of proportion than what you expect, so it is basically epidural hematoma that has happened. I now, if I find any patient like this, I give 1 dose of Solumetrol, steroids. Steroids help them with the pain. Need to deficit, then you have to go in and evacuate it. Analgesics and pain and rest. That is what I give. I've got a few cases who had out of proportion pain, and you can understand if a normal standard patient is after 2 hours, they'll say, "Oh, sir, I'm fine and don't have any pain." And but if they are saying, "Oh, I'm having too much pain in the back," any pain in the leg? No, there's no leg pain. But there's no deficit. I can pass urine, everything, but there's too much pain in the back. If the patient says like this, be sure that you've got an epidural hematoma. One slide, not a debate, but I think it may be better for fusion as well as stenosis surgery, because you've got more degrees of freedom with 2 hands. This is a slide which I have borrowed from Atmaranjan. So curse him if you want to. So these are some of my cases, like done a UB TLIF standard. So this was a case, almost a grade 3 listhesis, which was partially reducible on positioning. We could do a UB TLIF on this. And again, listhesis, UB TLIF. So yeah, these are standard cases you can treat with UB TLIF. This is one of my cases. I used an expandable cage, achieved a good lordosis, but these are some of the cages through which you cannot put in a lot of bone graft. So in the follow-up, this patient failed. But this was a patient who had a chronic CLD, liver failure, chronic liver disease, liver failure, and almost maybe two months after surgery, we came back with pain, and he was unfit for any revision. So I had a word with the gastroenterologist and told them that can we give him teriparatide for some time at least, if not operate. So again, teriparatide is not a very good drug even in liver failure. But with discussing with the patient, we started the patient on teriparatide. After 2 months, his pain gradually decreased. Somehow he feels and became asymptomatic over time. So salvaged conservatively, but since then I've been very skeptical about using expandable cages which do not allow putting in a lot of bone graft through them. But new cages that have come up, they have a provision of putting in bone graft through them. A lot of literature now comparing UB TLIF with MIS and showing advantages. Even there are RCTs. We are organizing this Asian UB meet for the second time in September. Last year we organized the first Asian UB meet. So this year in 22nd, 27th September, we're going to 26th and 27th, we're going to organize the Asian UB meet in Kolkata. All of you are kind of welcome. There's a website which has all the details, and registration will be starting soon, and you can register through the website as well. We'll have more than 10 international faculties coming from UK, Spain, Thailand, Malaysia, Singapore, from Portugal, almost 12 international faculties and close to 35 national faculties in this meeting. And it's more kind of a discussion as the subject, our experience, as we gather more experience. This is a platform where we share our experiences, and more kind of interactive experience sharing platform rather than didactic lectures and the kind of because I think UB, the indications and the outcomes and the extended indications, these are still evolving. And through this meeting, we are trying to discuss all that and explore the horizons of UB surgery. And this is the website for Asian UB Meet. The website is live now, but registration process will be starting in a few days. You're all very welcome. So this was last year's meet. A lot of eminent faculties were there, and these are my mentors. Thank you very much. Sorry, 24 hours through the hole itself. So at introduce, I take the first second dilator. Under vision, I place the second dilator in the epidural space. Through the dilator, I put in the tube, then take the dilator out.
From where do you harvest
Bone graft from the lamina. You know, if I'm doing a T-leaf, I would use more and more Kerrison punches. Less drill, more Kerrison punches. Take the IAP out in a chunk, and take the whatever bone I can harvest from the lamina, the IAP and the SAP, and from the caudal lamina also, I preserve that. No, I don't use artificial bone graft. Because the end plate preparation is very meticulous. You have exposed the entire end plate, and whatever bone that I can harvest from lamina and the IAP, SAP, I think that is enough. Yeah. So same amount of bone I can harvest from in MIS T-leaf, tubular T-leaf also. No, I do all my surgeries under GA. Yeah, that's fine. Yeah, that you can do. On the GA, absolutely. Absolutely. Under GA. No problem. So the anesthetic protocols are like that. We've been like all my T-leafs, even if I'm doing minimally tubular or endoscopic, they all, if I do in the morning, in the evening, everybody we make them mobilize. My physio will go, my team members will go, we'll mobilize them, and most of them go home the next day or the following day. Yeah, we start buprenorphine patch. We start this buprenorphine patch on the evening before, and give a loading dose of 600 milligram of gabapentin the evening before. So depending on the patient's build, either we give a 10 microgram of buprenorphine patch or a 5 microgram buprenorphine patch. We give them the night before. And so that is what we start. And post-operatively, we do a paraspinal block over the TP as well. And we do a lot of local infiltration. And post-operatively, we use a combination of this buprenorphine patch, gabapentin, and depending on the patient's creatinine clearance, either paracetamol or diclofenac.
So I just wanted to ask, right-sided pathology, what do you do for right-sided L5S1?
Right-sided L5S1 is so I will stand on the right side, switch portals.
Okay.
Otherwise, if it is if I'm doing it for stenosis, and so I can still do it from the left side, because I know I can decompress bilateral nerve roots very adequately. And if I'm doing a discectomy on the right side, I will stand on the left side, tilt the patient towards my side, and make the incisions on the right side and operate like working portal with my left hand cranially, and viewing portal left hand cranially and working portal right hand caudally.
For mainly for T-leaf only, I wanted to ask, because
for
it
T-leaf,
helps.
Yeah, T-leaf from right side L5S1, you have to go right and you have to switch portals. Ashwin Khandage technique. Not his technique, but he's popularizing it. Yeah. Thank you. So the idea of this talk mainly was to kind of tell you that UB surgery is truly minimally invasive. And if you follow the principles, you're doing a better work than tubular surgery. This is the crux of this talk that I want to message that I want to convey.
Hello. Anybody have any energy to see this surgery?
Hello. ચાલુ છે
Bhupesh,
Hello, yes sir.
you want to show something or
Yes.
shall I proceed with the talk?
We have one transcam infusion surgery. So if anybody is interested, if
Yeah,
people,
I think you can show one level because
yes,
you have to
one
show
level only.
how
Vasan,
quick
tilt
it
kar.
is compared to any other procedure.
So we have already
15
put.
minutes you can do dissection
Yes.
and do the cage.
Yeah, 15 minutes. Just give us 15 minutes. That's it. Okay.
Yeah.
Chalo. So we are in the center and the lateral in the center. You see the Siam? Just show the Siam. Guide wire.
Okay.
Guide wire. Can you see?
Yeah, yeah.
So now I am proceeding with the knife. Dilatation and cannula insertion. Okay. So we already finished one level and we already put some screws also. We are working, me and Rohit are together, so he's putting screw and I'm putting a dilator.
Okay.
Shoot.
So are you getting burnt or
Sorry?
are you getting burnt because of double reading?
Yeah. Maybe lateral.
Because you also will take Siam and he also.
No, we are taking together.
Yeah.
So
No,
we
we are
have
working
symbiosis a bit.
Yeah, simultaneously.
Okay.
So you say I am saying the lower part of the foramen, so it is a safer because there is no any neural structure in the lower part. Hello.
Lateral view, can you show?
Yes, we are just
Yeah,
showing.
can
We
you-
are
taking
okay.
the lateral.
So we are in the lateral. Now I am just about to remove the guide wire and just hammer my cannula position. Shoot. Okay. So I little bit manipulate. Okay. Shoot. Okay. So now I'll insert the cannula. Just
Show the AP also.
AP, shoot AP. Chalo fatafat.
So the needle or the dilator has to be in the center of the disc.
Yes.
Both in
yes.
AP and
Yeah,
lateral.
AP and lateral. To
Both-
tilt kar ja baju.
Both in. This is very, very critical.
Yes. Otherwise your
once you-
cage position may not be appropriate.
So once you put the needle properly, then
Okay.
rest is very easy. Very
So now you
mechanical.
see, we are in the center.
Yeah.
So now I'm proceed with the shoot. Okay, done. So now give me curate. No, that's yeah. So these are the few instruments which we are just trying to.
This is from which company?
These are the fuse for the abacus and few are from the Solco. So we are mixing both. These are the cup curate box sigil. Sorry. So you see now we have removed the part of the disc.
Yeah.
अंदर थी काटने મારા પર છોડી દીધું કે તમે કાઢો હું કંઈ નહીં કરું એટલે અંદરથી કાઢવાનું કીધું so lateral come on the lateral view. So this removes a lot of disc for me.
You have the expandable trimmer also, no?
We don't have.
No, you don't. Okay.
But I think this is enough. Curate.
You have the ring curate?
Rim curate.
Yeah.
Yes, we have curate, rim curate. But initially, before that, I'll use some other instrument. Now curate.
Okay.
Angle curate. So this is the can you curate? So this is the curate. So end plate. I again direct my bevel towards the upper end plate. So I want to remove the upper end plate cartilage. I already started getting a gritty feeling. You heard, if you can hear that feeling. Shoot. Okay, so upper end plate.
Yeah. What is the size of the cannula?
This are 9 mm cannula.
Okay.
So you see the material. So I again directed my cannula towards the lower end plate.
Okay.
shoot. Yeah.
नहीं भाई.
So good amount of disc material. Again, I go move back to the upper end plate.
Needle.
Bone graft ले लो. नाकी तो bone graft. नाकी तो cannula में.
Sir.
भरते cannula में भरता.
Sir.
चलो disc forceps. So we have curated and
Sir. Sir.
कोई हाथ में नासिर हाथ में कॉस्टिस पकड़.
These are correct.
So Dr. Mahesa, you want to add anything in Transchem infusion or any other members?
No, nothing. This is a ring curate.
Yes, we ring curate we did. Ring curate initially we
Yeah,
used
okay.
that ring curate. They give me ring curate can give. नहीं, फिर क्या की? नहीं, बीजे कहते हैं. Yes, this is the ring one.
Okay. No, the articulated one.
No, not articulated one. This is a flat one. But again, I can move up and down my cannula. So I started. You see now, gritty filling is there for the end plate. And if you see the curate, it's completely. Show me the lateral view. Lateral ija.
Okay.
કેટલો કેજ નાખશું 12
नहीं यहाँ 13.
13 નાખશું મને લાગે 12 વધારે સારું પડશે નીચે બહુ મોટું હતું. So if you see shoot, so my entire can touch the lower end plate. Similarly, my curate is touching the upper end plate so that there is no intervention. Shoot. Okay.
Can you show the CM picture? We
Shoot.
are not seeing. Okay.
Shoot. बताओ.
Yeah.
Oh, sorry.
Yeah.
उल्टा हो गया. Shoot now. So I am touching the end plate. Okay. I can feel. My end plate preparation is almost done. Chalo. So this forceps, and then give me a bone graft. So while putting a bone graft, I'll just insert the cannula little more so that my bone graft goes anteriorly. Okay.
So what?
I'll insert the cannula more
What
anteriorly.
graft are you using?
I'm using the कौन सा है?
Okay.
G bone अपना standard. Shoot.
G1. Okay.
Five cc for each level. Okay. Shoot. Okay. So now.
Okay.
12.
12.
12. Okay. Give me guide.
R12.
चल जल्दी ले ली तो मैंने के लाइन मुकी रखी उसे
अंदर ले दो और थोड़ा नीचे ले जा थोड़ा बता एक बार.
So what is the size of your cage?
12 mm. So with our cannula is 9 mm. I can see the 2 millimeter, 3 millimeter gap between upper and lower end plate. So
wire.
In lower level, we wanted to put 13 mm, but somehow our assistant heard at 12 mm. So he just gave 12 mm. Then once I put inside, I said, why it is not adequate? He said 12 mm. Shoot. Okay?
Okay. Yeah.
So this has to be very quick.
Yes.
Shoot. Don't wait for here. Shoot.
Show the CM.
चलो. Shoot.
थोड़ी सी तो बना दो. हाँ.
Shoot. बताओ. Okay. चलो AP.
Yeah.
artery lagaओ जी नासिर.
Maybe you can do some compression in the end
Yes, yes, yeah, we will do.
once you put the rods.
Yeah. Okay. So we are exactly in the
Yeah.
center. कसौटी चूतिया बटिया છે બધા કાઢ નાખ ખોલી ગયું કાઢ નાખ
चल एक needle.
Okay, so 2 level finish. Yes, Mahesh, you can continue with your talk. I think we
Yeah.
put in last level is there.
Okay, well done.
Okay, thank you.
बंद कर दो.
So if our colleagues wants to see last level, we can also show them. If you want to continue with the talk, you can continue with the talk. Okay?
It's already 7 p.m.
Yeah, that's why I'm
we
saying.
are running.
Yeah, you
today,
just proceed
so-
with your talk, okay? कट शॉट
Yeah.
ये माइक बंद कर दो मेरा रोहित का बाकी खाली टेलीकास्ट चालू रखो एक छोटे पीआईपी में ओके
And if you want to see, I will show 2 thoracic cases. One is transformed discectomy and one is interlaminar endoscopic excision of arachnoid cyst. So this was an elderly patient who came with the left-sided pain in the chest and abdomen. She was investigated for abdominal pathology like gastric ulcer, any abdominal pathology, but everything was negative. And finally, she had been to an Ayurvedic physician who did this MRI spine and got this pathology detected. So basically, patient has a calcified disc at D10-11 level, which is causing compression of the exiting route as well as the cord. So this is the main pathology. You see the calcific mass, which is compressing here. And these are the images. Sagittal image. There is no other pathology in the spine except this compression here. That is the pathology there. You can see the compression there. So basically it is an anterior compression, so there is no point in doing any posterior surgery here. And the best way to tackle this is transform technique. So for transform surgery, for thoracic spine, you have to mark the level. So the margin for error is very less in thoracic spine because if you go anteriorly, you have the lung and major vessels. If you go medially, there is cord. So the corridor for our entry is very small. So that's why only if you have enough expertise, then only you should try to do these surgeries. So another important thing is not to miss the level. So what I do is I take multiple needles in the lateral view and I keep one needle at suppose D12 or L1 level and it will be there throughout the surgery. So that you know that is D. don't make any mistake. So that is the AP view. Can you see that? I'm just at the medial pedicle line in AP view. And just cross the medial pedicle line now. And then we take a lateral view. So you can see that the needle has entered the disc space now. So that is quite acceptable now. So most important thing is in placement of initial needle. Once that is done properly, then rest of the steps are very easy. The rest of the steps are very easy. If there is any difficulty in putting the needle, then what you use is you can use a Jemshedi needle and go in, because here the exiting route is not a problem. Even if you cut it, nothing happens. Especially in the upper thoracic spine, anything above D8, you can always you have to use a Jemshedi needle, but because otherwise the rib feed will come in your way and you'll have to do the drilling under vision. So with the needle, it's very fast. You can see that the needle was in the center of the disc in both AP and lateral views. Now we change the needle to a guide wire, and then we put the dilator inside. So this is 7 mm dilator, which goes inside. So we're just entering the disc now. So initially the inclination will be more vertical because the facet also comes in the way here. So
आइसोलेटर
नीचे बताओ ना, वो
नीचे आओ ना तो लेटर लाओ तो और माथा पर टिल कर, माथा पर टिल कर, माथा पर टिल बस बताओ तो नीचे आइए। हाँ नीचे बस, हाँ बताओ ये टिल कर माथा बाजू बस बताओ
नीचे नीचे नीचे
बताओ बराबर दिखा बोन पहले पहले बोन रखा ओके हाँ लेटर नीचे ये सुन रहे थे क्या तो बोन से मोड़े थे ओके हाँ बोन रखा ला ओके दीदो हाँ अगेन नो ला ओके जा तो नहीं रहा आइए बताओ बताओ आ શું છે નરેશ આ દિવેલ લોકો बताओ 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 ओके चल कैमरा ओके बताओ એમ ઢીલું કેમ થઈ જાય હે बताओ તારું ઓલી ઢીલું તો આય ના નાખતું તો મોકલા અંદાજી ના ઉઠી જાય ચલો बताओ सर मस्त पोजिशन ठीक है सर हां अभी मस्त है हम नहीं आता चलो
करना तो आप सब फाइनल राइटर अपन हां बोले चले कंप्रेसर फोटो सेट क्या है हां नहीं इधर बाकी है तो पता ना तो मैंने नीचे कर चल मेरे ऊपर हां चल सवा साथ पति गया चले साहब खाली ત્રણે ફોરામેન માં અરે યાર સ્ટીરોઇડ એક લિગ્નોકેન સ્ટીરોઇડ હે ને સાહેબ ને ખાલી નીલ આપી દીધે બદામ ભરીને સાહેબ હા એ સિરીજ દેવડું નાખી દેજો પેક કેલા પડે લોટો છે બહુ મસ્ત થઈ ગયો રોનક આલો નાખી દેજે માગે હવે તમે આમ તો ટાઈટ કરજો ને પાછા તો ઉભો હવે જો આમાંથી કેજ બેકઅપ ના થાય એના માટે રીઝન એ સીરીઝ પોસ્ટિવ વર્ટિકલ લાઈન છે ને એ કેજ ની પોસ્ટિવ વર્ટિકલ લાઈન કરતે નાને કેજ તો કેજ ટુ ધીસ બેકઅપ લાઈક કમ્પ્રેસર વર્ટિકલ માં 30 મિનિટ માં 40 મિનિટ માં મોટી મોટી નામ હે મોટી મોટી ત્રણ લે હે ને નીડલ આ Third. Nico 7. Nico Paco. Third. जल्दी आरसीबी का लगा रेडी ओके
Belum tips saja. Berjadi. Saya nak depan. Jalebi kan ada. Little and shiv का भी एक बता hanya ini dulu nih gue aneh kayak lewat kan cara ini kan surgery aja क्या माने जवाब बड़ी बड़ी जवाब nih तो बता दे टेबल बस पे ये ना के बसन बीच पर ले तो बैठ लीजिए ये वाला मालूम नहीं है मुन्ना भाई एमबीबीएस है उसका तो मन क्या हूं मालूम भी आज बात चल भाई ने बोला है डेड बॉडी लाने का चले जाए ले लो भाई ने बोला बनने का हां बनने का बिया भी करेगी dari apa tu namanya? Ini jadi jadi. ऐसे. ऐसे या नीचे ऐसा. Good. कोई हाइट ऊपर कर दो. ये लिया फ्रेश है. एंकल नहीं आ गया. समझे? आज वो फ्रेश है. Good. Good. मैं रेडी को कौन सा अंकित दोसा का गुड तो बीमार काल से पकड़ो ना हो गुड